that has been happening, we realize also that the risks still remain as we see what is happening in other countries, in Europe, in North America, and in other parts of the world. We are aware that as a country, we are not immune from the fact that there can be a resurgence of the infection. And over the last few weeks, we have indeed been quite worried in seeing what Prof. Abdul Karim refers to as some flames which are coming up here and there, which we need to make sure that we can extinguish. Because as we would remember, even around from March, April, especially when we went into June and July, some of those flames started to be real felt fires, starting in the Western Cape, in Cape Town, and then spreading into the Eastern Cape and coming to Gauteng and spreading throughout the country. Where we are currently, the rest of the, most of the country remains fairly stable, but there's already very significant signs that indeed the danger is there. We have seen already over the last 2 to 3 weeks a consistent rise, especially in the Eastern Cape province, and it's been rising. The numbers have been rising daily. Numbers of admission, not only testing positive, number of admissions, numbers of those who needed ICU treatment, and also in terms of the mortality rates have also been rising. And over the last few days, we've seen also that again in the neighboring province, in the Western Cape, that is, there's a bit of a rise as well. So we're monitoring all this very tightly, so that, and we've already been discussing with the Eastern Cape province. You might have heard even yesterday that even the premier of the province is also in isolation after also having tested positive. So we're working with the province to try and make sure that we can be able to contain those flames in the province, because we know the pattern. Once that gets out of control, you know, it's going to spread throughout. And of course, the biggest danger for us, we know South Africa, you know, and Christmas. Now, already the Christmas fever is already starting, and people are starting to move. And we know that the virus doesn't move on itself, but it moves through people. And we know that as we go towards December, in the next 2 weeks, and worse so as we go towards the middle of December, the roads will be full. Gauteng people from Gauteng, from my province of Limpopo, the N1 will be full, the N4 will be full to Mpumalanga, the N3, everywhere. People will be moving from the metros to the small towns and rural areas. And as that movement in huge numbers will be happening, those who will be unknowingly carrying the virus will be also moving with the virus, going to different areas. So those are the things which we are concerned about as to how, you know, the measures to balance, you know, I mean, human beings are basically social beings, and therefore it's very difficult. This period has been very difficult of, you know, whether you call it social distancing or physical distancing, because as human beings, we thrive on, you know, social interaction. So this has been very difficult, and of course, having an impact also in terms of the economy. So these are indeed very difficult times. Difficult in terms of the health profession. How do we make sure that we can overall keep providing the services, providing the health education, make people, you know, aware that indeed the health services are still available. If they need treatment, they need to approach our health facilities. But at the same time, also making sure that in the provision of those services, we make sure that the health practitioners are safe, because we don't want more health practitioners to get infected, but also making sure that as health practitioners, we can also do everything possible to protect the public, but also making sure that the education about the fact that this virus, this invisible enemy, we don't as yet have any definite treatment and vaccination for it. We know that there's a lot of hope, there's a lot of promise. Over the last few days, we had the announcement by Pfizer that they are very far advanced with a 90% efficacy. This still has to be proven, and that there are many other companies which are also doing the research in terms of the vaccine. But it's still a long way, because even as you had the announcement by Pfizer, it was very clear that in terms of reaching a state where it can be very publicly available, it's going to take quite some time. We hope that there will be, as many other companies are doing research, they will come with some of those which will be able to be available at an affordable price, which can be made available to the public. But while waiting for all those, we must keep very strong on the non-pharmaceutical intervention, the basic non-pharmaceutical intervention, which indeed have worked for us. Making sure that, the sanitizing, washing our hands with water and soap and with sanitizers, making sure that we keep social or physical distance, avoiding crowded areas, and all those we believe that must remain in our toolkit in terms of making sure that we can prevent the spread of this disease. As a country, we are indeed very proud of our training of medical and dental practitioners. We believe that we have very high standards, and we must keep those standards. And I'm sure during the course of your conference here, you're also reflecting, I've seen that you're also reflecting on training. But we also have to make sure that we can also massify access through expanding also access in terms of more oral hygienists, more dental therapists, so that more and more South Africans can be able to access the services. Now, as I conclude, ladies and gentlemen, I want to take this opportunity to indeed express my appreciation to all health workers, because they are there in the front line. Without the frontline health workers, we would not be where we are, where today we can say that we are still in the midst of the pandemic, but we have done much better than many people have expected. If you look back at the modeling in terms of how many people, by this time, the fact that in terms of some of those models, our health facilities would have been overrun, our ICUs would not have coped, and in terms of fatalities, it was expected that by this time we will be somewhere in the 40,000s. 20,000 is still a big number, but we are indeed very grateful that so many other lives have been saved. So I want to wish this conference all the best. We will be looking forward to the papers which have been presented. I'm told that some of those papers will also feature internationally, and we indeed wish you all the best to all the researchers and the presenters. We're looking forward, and I'm sure they will not just remain academic, but they will also help us to improve our ability to provide oral and dental health, but also improve the long and healthy life for all South Africans. Thank you very much, ladies and gentlemen.
Thank you, Deputy Minister, for the inspiring presentation. And I just want to, just highlight a few things here which the Minister has covered. The issue that, the first one is the fact that we should actually try to look for solutions which will help us to obtain universal health coverage. As we all know, most of the curative approaches focus only on a few people, and they tend to be quite expensive. Not that they shouldn't be done, it's important to have these. However, we should also include research which focuses on measures to obtain universal health coverage. I also want to highlight the fact that the efforts to contain the flames, as it was presented, of COVID, these are actually very important, and more so because most of the people at the moment have actually, it's like there's no COVID at all. And I was actually very impressed by the president's speech last time that we need to continue using all measures that are available to contain this virus. And also from our side, I'm glad to hear that efforts are being made to make sure that health workers are safe. Indeed, we have lost quite a few of our colleagues, and it is important for us as health workers to obviously be recognized and be given all the opportunities that are available to ensure that we are safe so that we can continue serving the nation. At this stage, I would like to ask Professor Hendricks to come forward and give you a token of our appreciation for coming here. Indeed, we are quite grateful for your presence here. It's important for us as the dental fraternity, when we ask you to come forward and give us a talk of this nature, to avail ourselves. We really appreciate it. Professor Hendricks, you can step onto the podium and hand over the present.
We'd like Melissa to come down here,
Oh.
please. And then this is the LOC committee who's organized this conference.
Oh, okay.
Melissa, you can come around, stand in the center.
All right.
Stand in the center, then we'll award you the gift. And also, President Bayat, you can join us, please. He's the president of the IBR.
Colleagues, we are going to go on a short break as we prepare the panel for the next discussion. So just a short break to allow the technical team to arrange and organize for the next event. Thank you, colleagues.
in 5, 4, 3, 2, 1.
Welcome to the second session of the 50th anniversary of the IADR, and we are hosted proudly by the Sefako Makgato Science University. My name is Patricia Ntuli, and I will be your host between now and the end of the program. I am so excited that once again we are together. Thank you very much for the great job that was done by Tim Modise, legendary Tim Modise, really held it at the helm this morning. It was really great seeing him in action. And all the speakers really did do well, and I'm so excited to see that you're all back online, logged in. And if your friends and family members and colleagues are not logged in, please do remind them to go to www.smu.ac.za/IADR/2020. That is where you can be able to stream us on YouTube and on all social media platforms. Before we took the break, we had the honor and the privilege of having the Deputy Minister of Health, who is Joe Phaahla, who finished up and just told us a very important pointers that I think we need to remember. The fact that, you know, we need to reprioritize medical services, and this was done during a lockdown and even now in South Africa. And the increase in the COVID cases in the Eastern Cape was one of those issues that has been looked at very importantly, meaning we need to adhere at all times, keep wearing those masks, keep sanitizing, and that social distance. Yes, protect yourself and those around you. Vaccinations and treatments were one of the things that we also spoke about around COVID-19, and also non-pharmaceutical interventions that are required. Very good to know that the training of medical and dental practitioners is one of the key things that our government is looking at when it comes to dealing with COVID-19, because we are aware that dental practitioners and oral health practitioners are really at the forefront and really working with an area of the body that hosts this COVID-19. So retraining and giving them the understanding and the support that is needing is very critical. Thank you very much to Deputy Minister Joe Phaahla, who was standing in there for the Department of Health in South Africa. I'd like to remind you once again that we do have our WhatsApp line where you can interact with us. Now, why is this WhatsApp line there? It's because you are part of this program. You might be logged in, you might have questions, you might have comments. How will we know if you don't let us know via the WhatsApp number or even via the social media platforms? The WhatsApp number is 064 656 0131. Please dial that number for WhatsApps and we'll be able to filter them through to the panel that we have right now. And also those comments on how great you are enjoying yourself for the past 2 days and just celebrating the centenary Congress for the IADR. The next segment, we are going to be having a talk and a panel discussion. With me on the panel is going to be via Zoom Professor Karim. Professor Karim is joined by Dr. Alison Glass and Dr. Nyati. We'll start off with a Zoom session with Professor Karim.
Good morning. It's a great pleasure to be with you here this morning. When we look at the situation with regards to the COVID-19 epidemic, what we have seen is from the day we had our first case on the 5th of March, that for the first 3 weeks, we had a very rapidly rising epidemic, doubling every 2 days. But then on the 26th of March, our epidemic slowed. This slowed because of a range of measures that were taken very early, declaring the state of disaster, closing the borders, closing schools, introducing the lockdown. But with that slowing down of community transmission, we knew that that was not going to be sustainable. And as restrictions were eased on the 1st of June to level 3, we saw the rise of new cases so that we went into our peak in July. Now we are in the post-peak trough, and our number of cases have been at a low level of transmission. But we have to expect that in the midst of a general low level of transmission, that there will be outbreaks that occur. And one such outbreak is one we are experiencing at the moment in the Eastern Cape. Now, it's not something we should get panicked about, because that's how the epidemic works. That's how the virus spreads, that there are these amplifying events. In the Eastern Cape, it seems that universities and schools may have played a role. And from there, it's now in the general community and transmission is occurring. What that has meant for us, it has meant that in the Eastern Cape, there's been a huge pressure on the healthcare system. And that's particularly severe in the Eastern Cape, because the Eastern Cape is one of the parts of our country that's least capable of withstanding this kind of pressure. It's the part of the country where the health services are most underdeveloped, they are the most poorly managed, they are the most corrupt, and they are in a situation where they were in trouble in the first wave. And so now we're dealing with the problems of a resurgence in that area. And I have little doubt that, with appropriate measures that are currently in place, we should be able to see those kinds of outbreaks, being contained before they end up in a situation of a generalized resurgence. How does that impact on the way in which we provide healthcare? Well, it impacts in a range of different ways. And one of the important ways is that dental care is often seen as elective. And so when hospitals are under pressure to see COVID patients and to allocate more beds for COVID patients, we see a situation where dental care often suffers. And that's been a bit difficult. And trying to remedy that has been among the challenges we have faced. Those challenges are not because there's a policy problem, because there is no policy against dental care. The problem is about perceptions of risk in healthcare services and the way in which that has worked in the past. And we've captured that, particularly for HIV and TB care, where patients have been hesitant to go into primary healthcare settings and even hospitals, because that's where they think the COVID is. And so we have to educate our public. We have to continue to ensure that we can explain to them that our prevention measures, our PPE measures, our triage systems will provide them with adequate protection so they can continue to seek dental care during this period of the pandemic. As they say, as we deal with this pandemic, they say that every crisis has its upside and it's an opportunity. And in our case, it's an opportunity to ensure that we are building resilient healthcare systems, because I can assure you this is not going to be, it's not our first outbreak, and it's certainly not going to be our last. We can expect that we will be seeing outbreaks on a much more regular basis, and we will be seeing these kinds of pandemics on a much more regular basis. So whatever we're doing now becomes the basis for building for the future as we will face epidemics in the years going forward. I want to just end off with, you may have heard the good news that the first of the COVID-19 vaccines that's in advanced clinical trials, there are 11 at the moment, and that trial released some results that indicate at a very preliminary level, because the data is not available yet, that some promising results are in the offing. And so it's very good news. Remember, humanity, our human race has never made a vaccine against the coronavirus before. This is the first time. So it's firstly good to know that we can do so. And secondly, that we have a pretty high efficacy vaccine in the offing. But we wait to see the full results. And we have to accept that we're not just simply going to go with the first vaccine that's available, because there are 10 more vaccines that are releasing results over the next few weeks. So we have to choose the vaccine that's most suited to our situation, most suited in terms of price, in terms of being a single dose versus double dose, in terms of how long its protection is provided, and so on. So there'll be a range of markers and criteria that we will use. And so I don't want people to get their hopes up that because there's a result announced this week that, in a few weeks' time, the clinics are going to have a vaccine ready for us, because that's not going to happen. Having a vaccine result is just the first step. There still is a regulatory process for approval, and the companies have to manufacture billions of doses, and then we need to distribute it and so on. So it's a long step. So we need to take the good news that we heard this week on a vaccine as the start of a process that we hope will help us get into a situation where we will be much better placed to get closer to the new normal and continue our lives in a much more constructive way. Thank you very much.
Very much, Professor Karim, and I'm hoping that you will stay with us so we can continue the conversation with the rest of the panelists. Let me give an opportunity to Dr. Alison Glass, who's a virologist at Lancet and has been dealing with the pathology around COVID-19. Very warm welcome.
Great, thank you very much. Yes, as mentioned, I'm a virologist at Lancet Laboratories, and I have the privilege, I think, of heading up the molecular laboratory at our head office, where we started with testing for SARS-CoV-2 on the 6th of March, one day after the first case was diagnosed in South Africa. And it's been quite a journey since then. We've done just over 1 million SARS-CoV-2 PCRs since then, and have certainly gained a lot of experience. And as Prof. Karim mentioned, we've learned a lot of lessons for the next pandemic as to how we will ramp up our testing more effectively next time around from the lessons we've learned this time. And I think it's been a very important time for viral molecular testing in South Africa, because we've had to very rapidly ramp up our testing capacity, and that's both in the private and the public sector. We've always been very geared for molecular testing for HIV because of our long history of battling that particular pandemic. But when it comes to other viruses, most of the molecular testing gets done at centralized laboratories, and there's suddenly been this huge demand for mass testing and quick mass testing at a local level. And that's provided a great opportunity for both the private and the public sector to grow our testing capacity. And I think South Africa's got a history of having extremely good pathology services, our pathology services rank up there with developed first world countries' pathology services. And we can be very proud of that. And I think given the number of tests that have been performed in this country is a testament to how we are able to offer a really excellent service to the public when it comes to laboratory testing. And we've experienced many challenges, but the pandemic has also created lots of opportunities for us, which I think will benefit us going forward for testing for other infectious diseases as well.
Thank you very much, Dr. Glass. And I'd like us now to also introduce and welcome Dr. Nyati, who is a CEO of an employee health and wellness company and is also a family practitioner. Thank you very much for joining us, Dr. Nyati.
Good morning to everybody, and good morning to you as well.
We are aware that COVID-19 has presented a lot of challenges, especially in the workplace. Could you perhaps take us through some of the things that you have done in your company and your organization around educating employers and employees around COVID-19 and the compliance of it?
All right, I'll touch on that. Let me just share a few thoughts which will lead to that point, if you don't mind.
Go ahead.
All right, thank you. We all know that it's just about, 11 months since we first heard of COVID, and there's been a rapid spread, globally. And this is like 102 years since the last major pandemic, the Spanish flu, that was in 1918, which killed about 50 million people, and about 300,000 here in South Africa. And there's claims that, as a country, we did not manage that very well, because the guys who came from the war, who were supposed to be quarantined in Cape Town, were released prematurely. And that led to a spread throughout the country, and we lost a lot of people. Now, with the current one, there hasn't been much time for the country to plan and get it stuck on the row, and also the fact that this pandemic was happening everywhere. So the equipment we needed, the stuff that we needed, reagents that we needed, were needed everywhere, and so getting those for the country obviously was a challenge. And some of the countries were saying, "Our country first, before you can give to these developing countries." All right. So basically, this COVID-19 pandemic has exposed fault lines, across many countries in the world, including here in South Africa. Problems that were pre-existing within our healthcare system were actually, exposed both in the public sector and, in the private sector. And provinces like my home province, the Eastern Cape, haven't done well. And one can go back to say why. Well, it's part of the legacy of the healthcare system that was inherited in this country in 1994. That has not really been turned around ever since then. And so it's no wonder that it's one of the worst affected provinces in the country before the peak, and also even now that we are worrying about the resurgence. It's the same problem. The inequities in terms of access to healthcare were clearly exposed. Those people with access to medical aids, like the Deputy Minister said, have been able to at least get access to healthcare. But people in the kind of province that I come from have not really had, that luxury. And as a result, the levels of deaths from that kind of province have been bad. And it puts then the question to say, what has been done to actually improve the healthcare delivery system on the ground, especially in the worst affected, provinces of this country. Again, the epidemic of corruption in this country has also come out very clear, because instead of people focusing on ensuring that lives are saved, some in critical, areas have used this as a time to actually, be corrupt. We have heard about the COVID-19 PPE corruption. Unsuitable companies getting huge multi-million contracts to deliver poor quality PPEs, and the consequent, risk to the healthcare workers, who many of them were getting, infected whilst doing their work. But it's also exposed that as a country, our manufacturing capacity for these things is actually quite low. We had to import most of the things that are required, and yet this country has a history of good manufacturing. It's only now that other, agencies like CSIR and others are trying, to come up with ways of improving, so that we can be self-reliant as a country. Public health education was exposed as far as I'm concerned, because yes, the president and the minister would stand up and talk, but at the end of the day, follow-up communication to educate people, especially through their languages, the languages that they prefer, was not so great. And then we say people are not adhering, to non-pharmaceutical measures. Yet the messaging for me was not good. It was in English most of the time, and it was not consistent. So people like me who've got private, channels, we've had to fill in the gap to actually educate people in their language as a way of trying to say, we need to get people to adhere so that we can minimize the number of people who are dying. Obviously, again, it's been mentioned that there's been a negative impact on a number of other healthcare programs, dental care, especially routine preventative stuff. I haven't gone to have my, 6-monthly, dental care services. It's almost a year now, and that's not good, Also, treatment adherence to chronic medication, things like HIV and AIDS, non-communicable diseases, it has been bad. There's been negative impact on immunization of children, because parents are afraid to go and get their kids, vaccinated. Negative impact also on, things like contraceptives. So I expect that sooner or later we're going to see a rise in the number, of people who are pregnant, but also in the treatment of cancers, for example. So the question then, that you asked earlier, the impact in workplaces. Obviously, workplaces, because the people come from the very society that is actually affected by COVID-19. So it was no wonder then that a number of workplaces, including mine, experienced a number of employees who were infected, and it's been quite heavy on employers because once you've got a case, then there's a protocol you need to follow in terms of ensuring that the whole place is disinfected and all of that. So the cost to preventing, to ensure that you are able to continue operating, but also managing, those has been quite heavy, especially to smaller businesses. But the other issue I want to raise, though, is that the frontline workers, especially in the public healthcare system, have been largely affected, by this thing, both in terms of the stress of worrying about getting infected, but also those who get infected or the colleagues who die from this thing. And the whole issue of occupational health services within the public health system, especially in the departments of health at provincial level, it has been a major, major problem. So for me, if anything can come out of this COVID-19 pandemic, is for the government to walk the talk, to ensure that occupational health, the health and safety of frontline workers is actually prioritized. Because at this moment, most provincial departments are actually doing very little. They were caught napping. I think going forward, there's the whole issue of the mental health services in this country. We spend less than 5% of our national healthcare budget annually on mental health services. All right, we are somewhere around 2.5 to 3% when we should be spending at least 10%, and that has been exposed. And whilst the focus has been on physical health with COVID-19, but the bigger issue that is going to be with us for the years to come is actually how to deal with the mental health impact. People who have lost loved ones, who have lost colleagues, who've not been able to go and pay their respects and all of that. So you're going to deal with a lot of complicated grief, and people with pre-existing health challenges, mental health challenges as well, they have not been able to really get proper and adequate care. We've only got 1,000 psychiatrists in this country for a 60 million population. So I think it's one area that the government has not been saying much. How are they going to address the load of mental health care challenges in the country? So I think I'll end there.
I'd like us to take it back to Professor Karim. Professor Karim, you made mention of the fact that in the rural settings and informal settlements, there's a lot of education that still needs to be done around COVID-19 and compliance. But we are also aware of the fact that access to clean water, access to healthcare is also very limited in these areas. And never mind the fact that when the pandemic started, or we were aware of it in the beginning of this year as 2020 started, there were a lot of myths. So how do we then ensure that in the rural settings, in the informal settlements, in the lower LSM communities, there's enough information that is given to our people in those communities? Over to you, Professor Karim.
Yes, you raise a very important point, and it was an issue we factored into our planning at the very initial stages. We were deeply concerned about two things. The first was that we have a sizable population of individuals who have HIV infection and who have tuberculosis, and they may have a more severe form of the disease. But the second group we were concerned about was those who may not be able to implement the two key strategies that we had available in March, which is social distancing and hand hygiene. And we knew that that was going to be a problem. How do you institute social distancing in a situation where that's not really practical or feasible, and where water for hand washing was going to be a challenge? So frequent hand washing was going to be difficult. So on that basis, the approach was to aim to try and find as many of the cases as possible, which is not easy given that many of them are asymptomatic, and to offer those individuals isolation or quarantine in government facilities, so that where it was not feasible, when a person was positive for COVID in their own homes, then there was going to be a government facility available. And in fact, the government accredited several of those to make them available. I think, as we have seen, that has achieved only partial success. And the reason is a very fundamental one, that for every case that we know that they are somewhere between, at this point, we don't really know, but let's just for argument's sake, say that there are, that the cases we know represent 10% of all those infected. In other words, we have about 740,000 cases that in truth, we may have more like 7 million people infected. Some have argued based on antibody levels that that's probably much higher. Well, we'll wait to see based on a representative sample of people with antibody levels. But let's, for argument's sake, say there are 7 million. That means every case that we know, there are 9 cases that we don't know. So to try and slow the spread of this virus, when you don't know about 9 out of every 10 cases, is a real challenge. And so in that kind of situation, increasing testing, has major challenges because you really have to do the testing in asymptomatic people. And that becomes a problem because the cost effectiveness of doing that and the capacity to do that is a challenge. But that's now changed. Now we have available rapid antigen tests. We have the ability to tell somebody whether they have an infection in 15 minutes or not. So as the technology has grown, our ability to cope and to implement prevention strategies has now been changing as well. So what was not feasible back in March and April is now feasible because of newer technologies that we have available. So even those individuals who are in a situation like an informal settlement, that we can actually slow the spread of the virus if we can get in there and institute one of the basic measures of widespread testing, isolation, and quarantine.
Professor Karim, in terms of facts and figures, has there been any correlation or any statistics that have shown how bad or how dire the infection rate has been in rural communities and informal settlements? Why I ask this question is because we are aware that there was a lot of mass testing that happened in such communities. But the result of this mass testing did not come out and say, well, there is more COVID-19 in such areas as opposed to the upper LSM or higher quintile areas.
Yeah, so we know some basic elements of the way the virus spreads. So we know that density is important, that those parts of the country, it's not unique to South Africa, but everywhere in the world, those parts of the country where population density is high, you get the highest levels of transmission. The second, we know, and this has been shown now in several studies using cell phone information, that mobility is this virus's, favorite friend. Call it best friend if you like, but one of the favorite friends at least. And that when you have a situation of high mobility, then the virus is able to spread. So those two factors play a role. What we have seen is that in our more rural provinces, the epidemic got there much later. And in some of them, they didn't really have a high peak like we saw in Gauteng or we saw in KwaZulu-Natal. Most clearly, that was seen in the Northern Cape, where the Northern Cape actually never had a peak. It has had a sort of meandering epidemic, and it's only really finishing its first wave as we speak. I mean, in this last week, it is now slowly coming out of its first wave. And it's because it's such a widespread area where the distances are so much that the virus doesn't spread quickly. It spreads more slowly, but it does spread. And so what we are seeing in our more rural provinces is that we are seeing high levels of infection. It just takes longer and travels at a much slower way in those settings. But as we stand today and we look at the cumulative prevalence of the virus across our provinces, this virus has reached every corner of our country. no one has been exempt.
No one has been exempt indeed, and it's something that we are all looking out at as South Africans. And I think the globe around, everyone is looking at the unfolding of this particular pandemic being COVID-19, and a lot of professionals are really geared to make sure that we get to a point where we understand this particular virus, but how do we understand something that we don't know where exactly it comes from? Am I correct in saying this, Dr. Glass? Because, you know, there's obviously the bat theory when it came out. There's the bat theory. There's various theories and conceptions. But as a virologist, could you then perhaps tell us the origin of COVID-19, if you are aware of it, and how we can then make sure that once we understand the origin of it, where do we start making sure that the testing can be aligned to understanding whether it's from from zoology or it's from botany, or should we stop eating meat? You know, should we stop eating certain fruits and vegetables because it was not spread, or it did not come from us giving each other high fives, something we don't do anymore. It did not come from us hugging each other. So where does it actually come from?
So a lot of our viruses that are commonplace at the moment all originate from animals. So over the millennia, viruses will be introduced from one species to another. And because viruses are very adaptable, they will find these opportunities to cross over into a new species. So, for example, HIV has been well studied and determined to have been a crossover from a chimpanzee simian immunodeficiency virus from bushmeat hunting over repeated introductions into humans until a strain eventually took hold and off it went. We know that our influenza viruses are avian viruses in origin, and the original SARS coronavirus did come from bats via a civet into humans. And so, although we're still trying to identify with certainty the exact origin of this virus, the evidence is there that this is another zoonotic virus that has crossed over. And one of the reasons why we are likely to see an increasing number on greater frequency of pandemics is as human populations grow and we encroach on the natural habitats that we haven't been in before, or where we start to concentrate different animals from different areas in close proximity, that we will encourage these viruses to cross over more and more. So I think that needs to raise awareness about how we deal with our environment. There's been lots of talk about how this has been Earth's way of giving us a wake-up call with regards to how we treat the environment. And I think there's a lot to be said for that, as we need to look at where there can be crossover events and try to manage those and monitor those areas. I think we already have a lot of expertise as to how to test for new viruses, and that was evidenced by how quickly we were able to identify what this virus was. There was very quick delivery of laboratory testing for this virus. I did have to chuckle in early March when a colleague was like, well, can I have my SARS PCR on my patient? And I'm like, well, we don't have a test for it yet. And there was great indignation on the other end of the line. And it was like, well, we've only known about this virus for 2 months, give us a chance. But the speed in which tests became available is actually quite astounding, and a testament, I think, to where science is at the moment. So I think we are ready to adapt our testing to new viruses. I think the key is to appreciate where these viruses originate from and try to be more attentive to those situations to minimize the risk of these viruses crossing over or reduce that risk.
Well, there's one thing that you've mentioned, is the fact that most of these viruses that we are facing right now are zootonic by nature. According to science, that's enough to make me stop eating meat, but don't judge me. Okay? If you see me eating a piece of meat, please, doctor, understand it is a plant-based meat that I'll be eating. It will look like the steak, but it won't be steak. So, you know, and another issue here is testing that you've mentioned, Dr. Glass. And when the pandemic started, we were worried because there was a backlog in the testing. And people would ask themselves then, will I die in the process of waiting for my test results? And all of a sudden, the testing period has become so much shorter and quicker. And the waiting period is just, you know, it's actually non-existent. In a couple of hours, you get your results. What technology went into play, and how many players within your field, in your industry, in pathology, had to come together? to make sure that the technologies are available in South Africa?
So definitely early on it was a challenge, and I mean we certainly felt it the week that the president advised people returning from overseas to go for their testing. We had a huge influx of people coming to our laboratories for testing, and it knocked us over then in March, and we suffered from that backlog that you're referring to, and we had to put measures in place to catch up with that. And then as other laboratories started testing, they experienced the same thing. But the volumes we're running now, we actually are quite relatively quiet compared to how we were in July, yet the volumes we're running now are significantly higher than what we were running in March, and we do it easily now. And how we did that was to ramp up capacity, and I think the challenge was, as mentioned by Dr. Nyati, was trying to acquire the equipment and the reagents that were needed. And we were a little bit behind Europe and the US in trying to get these tests set up, and it was that problem of getting in all of that from overseas, because it is all imported. And I think that does speak to the importance of us in South Africa looking at ways of increasing our own capacity to be able to manufacture what we need, because throughout, especially lockdown level 5 and even into 4, just trying to get those things onto a plane to come to South Africa was a challenge, and every morning it was like, what do we have? How many tests can we run today? I think the opportunity it presented was it did lead to a lot of collaboration between the different laboratories, both within the private sector and within the public sector, where we exchanged ideas. If somebody had found a new test kit or reagent that could speed up the process or that was more readily available, we would share that information with each other. We collaborated with the NHLS to share ideas and to help, and even where we were short of reagents, we would meet halfway, in a parking lot somewhere, and say, okay, well, we've got this, let's swap for what you need. And it did lead to a lot of really good collaboration that I hope we will see continuing going forward. And I think a lot of the suppliers ramped up their capacity, and so it took a few months, but we did settle then into a process where we were able to get back to getting reagents in successfully, and where we'd ramped up our equipment and our staff and to a point where we could then process the required volumes. And I think we ran at our capacity for about 2 weeks in July, and then the numbers rapidly dropped off after that, and now we actually quite comfortable with the processing of the volumes that we've got, and that's why the results come out a lot quicker. Of course, I think there needs to be that understanding that when demand goes up, it does put pressure on those systems, and every lab has a certain capacity, and if you go over that capacity, it does slow things down again. But at the moment, I think both in the private and public sector, our capacity is able to cope with what's currently needed, and hopefully we've put in enough reserve so that if numbers do go up again, we are able to cope with that as well.
Dr. Nyati, you made mention of the fact that we are now at a place where occupational health and safety is quite critical. Now, when you think of occupational health and safety and environment, you think of construction industry, you think of factories, and that's what, mines, that's what it's been like. So if someone wants to go and study this particular profession, that's all it has to do with. But all of a sudden, it seems occupational health and safety in the workplace all round is becoming critical. How do we ensure that OHS is implemented in a workplace? Because as you are aware, that right now the economy has opened up. So we are fighting a battle of livelihoods versus lives. And it is important for us to have a livelihood, but lives are more important. So that's where occupational health and safety comes in. So how do we ensure, and not only from a governmental point of view, but from an organizational point of view, that we are adhering and we are informed?
Yeah. Well, that's a very good question. Historically, obviously, the mining sector, the manufacturing sector, have always been the areas where issues of health and safety were quite a priority. But in 1993, in this country, we we had this act, it's called the OSHA Act, or Occupational Health and Safety Act 85 of 1993. And basically, it's an act that forces employers to ensure that employees do not get to be sick as a result of being in the workplace. Meaning the employers have a responsibility to provide a safe and healthy work environment for their employees. Now, and this is across all sectors. So, but the challenge, though, has been that the enforcement of that act hasn't been, good. The Department of Labor, is supposed to send out inspectors to different organizations or employers, to actually see if there is compliance. But even before that happens, employers are supposed to get, organizations, with OHS experts to come in and do a compliance audit. Firstly, do you have an OHS policy as a company? Is this policy signed by the CEO or whoever is the accounting officer of that organization? Do you actually have health and safety committees? Are they actually active? Do they meet monthly to look at issues of health and safety? And when they make recommendations to the employer, does the employer listen? If not, do they then go to Department of Labor to report that our employer doesn't want to listen on these issues? So it needs, employers, starting from the accounting officers, to realize that they are ultimately responsible for the health and safety of employees. And if anything goes wrong, that CEO, that accounting officer is ultimately responsible. They can actually be jailed for this. But that message isn't coming through enough. So most accounting officers or CEOs do not take issues of health and safety seriously. Up until something happens, like Marine Roberts, where there was a bridge in Sentin that was being built, and then it collapsed and some people died. Obviously now the CEO of Marine Roberts has to be called to account to say what happened. He is supposed to make sure that there's proper structures and processes, delegate certain responsibilities to certain people below, but when things go wrong, he is supposed to, account. So we don't have that culture of compliance, even amongst, private sector, companies. And therefore, what this requires is that unions, or employee representatives are supposed to actually champion issues of health and safety for their for their members. Department of Labor must do regular audits, okay? If those things can happen, it will change the picture in South Africa. When it comes to the government sector, already by 2008, Department of Public Service and Administration issued, an integrated employee health and wellness, framework for all departments to comply to, which has got amongst the pillars issues of safety, health, environment, risk, and quality assurance. However, most departments have not gone beyond policy to actually run programs of medical surveillance, look at who are the employees who are actually, most at risk. Obviously, each organization has got different, risk exposure. For example, if somebody is at SAPS, if you're working at forensics, you may have a different exposure to somebody who's working in the area shooting range, So the type of screening test surveillance that needs to be done depends on the organization and also within the organization. So we need to now take seriously. What has been maybe a bit of a worry is that organizations like NEHAU, DINOSAS, have actually been raising this issue ever since this pandemic, came in, to raise the issue of health and safety. They even wanted to strike at a certain point. However, the response from the employers has not necessarily been a positive one in terms of ensuring that they put measures in place, which is why I said I hope the legacy of this pandemic is that there will be a change in the mindset of those who are leading and managing, so that people don't get to be infected, or get other kinds of occupational diseases as a result of actually doing their work.
Now, you deal with a lot of employees and employers. In those settings, if someone comes in and says, I came to work, I did not have COVID-19, and all
Yes.
of a sudden I contracted COVID-19 because
Yes.
a colleague of mine who works with me in the open plan
Yeah.
all of a sudden had COVID,
Yes.
but she only found out later because we
Yes.
know that other
Yes.
people, the symptoms take much longer to
Yes.
come out.
Yes.
And I come and I present myself to you
Yes.
as my physician.
Yes.
And having the understanding of the employee wellness programs.
Yes.
What are the steps that I, as an employee, should be taking? Can I go to the labor department and say, well,
Yes.
this was not an injury at work, but I contracted disease at work? But can we even prove it? Because I was commuting from
Yeah.
home to work.
Yes,
Can
yes.
I prove that it was my colleague who tested a week before?
Yes. Well, it's obviously a bit difficult to actually pinpoint that I got infected at this point. However, as the levels of the lockdown were being, relaxed, there were regulations that came out to say, as an employer, this is what we expect you to do. You need to make sure that everybody who comes in is tested in terms of the temperature before they come in. There must be a committee within the organization that is responsible for testing people coming in, visitors or employees, check the symptoms, and those with a high temperature or the symptoms, that are pointing towards this, or recent exposure to somebody who's positive, those people are not allowed in, but they are channeled to get healthcare, cover, healthcare services. So that has been what has been happening, and obviously, irrespective of whether the person got it outside, they are a risk to the business. And therefore, as an employer, you have a responsibility to ensure that they get tested. So in my organization, we had more than 10 people who got infected in a 3-month period. And this is an organization of about 50 people, full-time employees. And so each time then that happens, we then have to trace all the contacts within the employer and get them to go and be tested at company expense and ensure then that there's 14 days of them not being at work, before we can allow them back. So it requires responsible employers, but also responsible employees, and for people to be able to be quick in reporting, because there's also the possibility of people not actually, telling the truth when you are doing those screening things. Did you have any exposure? Did you go to any funeral? So we expect a bit of honesty from people as well.
It's an honesty game, and it needs to start from the top all the way down. And powers that be, please be honest, because at the end of the day, if you as our leaders don't show us honesty, did you go to a funeral? Did you go to a party? Was there social distancing? No. And we don't want that, because at the end of the day, we need to protect ourselves and others. Professor Karim, if you can still hear us, I'd like to find out from you. The malaria virus, or malaria, the season is coming up now in the Southern Hemisphere. Malaria presents itself with symptoms of high fever, a runny nose, and the likes. And then we also have issues of pulmonary hypertension, which are also, providing symptoms that are very similar, that you'll have shortness of breath, you would feel a bit of a chest pain. How do you then educate those who are frontline care workers around knowing the symptoms that might be similar to COVID-19, but also going then and testing further to ensure that people, especially who are reliant on public health services, are not given the shorthand when it comes to screening for COVID-19?
So we have a very straightforward process to deal with this, in that we expect that there will be many individuals who have symptoms that are consistent with COVID-19, but actually do not have COVID-19. The approach we have taken is to put together a set of criteria that would warrant having a test. And having any of the symptoms of COVID-19 is a criterion in order to test. So even if a patient might have malaria, or might have influenza, or might have measles, doesn't matter. We still will test them for COVID to eliminate COVID as a possibility if the patient has, or the clinician or the carer of the patient considers that COVID may be one of the differential diagnoses. So that's how we deal with it, and that's pretty standard. It's not a It's not something that's unusual. What is an issue is that once we identify someone who has the infection, then there's a whole range of things that have to start. One of which is that that individual needs to be contacted as a matter of urgency and advised to go into isolation. The second is that we need to know all of that individual's contacts. So we do want to minimize the number of individuals that are wrongly determined to be positive. And fortunately, the tests that we have, like PCR, are very accurate. So it would be unusual for us to say that this person has COVID-19 or has the SARS-CoV-2 virus if they actually don't. So the false positive rate is low. So that's why we're quite confident when somebody is positive that we can proceed with our prevention and mitigation steps.
I'd like to come to you now, Dr. Glass. Dr. Glass, in terms of history and what we have seen with other viruses, this COVID-19, we know SARS virus is no longer a part of our community. Do you think we'll get to a point where COVID-19 will be history? Or do you think we'll get to a point where COVID-19 mutilates or changes and becomes stronger and is called another name?
So my personal opinion, because we still have to see what will happen, but just if we look at other viruses and how they tend to play out, and especially around respiratory viruses, my personal opinion is that SARS-CoV-2 will become part of our human infection. So when we do a respiratory virus panel at the laboratory, we test for influenza, we test for rhinovirus, we test for a number of other human coronaviruses. And I do think that over time, SARS-CoV-2 will become part of that. We will still see infections. They will become less as people adapt to the virus and the virus adapts to us. But it will be part of those viruses that make us sick from time to time. I do think it will be dependent on how effective the vaccine is and how effective the vaccine is distributed, and whether or not the vaccine gives long-term immunity. And we know that viruses do adapt and change, and whether the vaccine's immunity does continue to provide protection if the virus does start to change. But that would be my opinion, is that it will stay with us, but will become part of our what we see on an annual basis with our influenza and all the other viruses that we're familiar with.
How contagious is the COVID-19 SARS virus as opposed to the ordinary influenza? And since you're saying we might see it stay with us for so long, this year, 2020, winter, I didn't even hear one person say I've got flu. Because we were all scared that people will assume that your common cold is now COVID-19 because of the symptoms that are presented. But how infectious is it as opposed to the common cold?
Well, so if you put a group of people together in a room, not everybody is going to get it if there's someone in that room with corona. There's an estimate that I think the latest about are north of about 2 to 3 other people will get infected from one person who's infected. But it does relate a lot to how the closeness of your contact and the type of contact and the point at how much virus the person is shedding. So if I can, and there was an interesting point that you said about the influenza, there being no influenza season this year, because that is true. There was no influenza this year.
Wait. There was no influenza, or no one wanted to report influenza?
So we've just been looking at our data to publish it because it's so interesting. We've looked at our stats of 2018, 2019, and 2020 of our other respiratory viruses to see what happened. And respiratory syncytial virus, which is a very common virus among especially children, which peaks from sort of Feb to May, we had no RSV season this year. We're seeing it now in September, which is very unseasonal for it because the kids have gone back to school. Influenza, there was no flu season this year. And granted, we were testing smaller numbers, but of those that we were testing, we did not see influenza, and neither did the NICD. And for me, that speaks so strongly of the effect that simple measures have. And although, the Deputy Minister spoke about, your non-pharmaceutical preventative measures versus, everybody holding on for a vaccine, but it's those simple preventative measures that reduce transmission of infectious diseases. And I hope that's the one message we take away from this whole pandemic, is it's those simple measures that can really impact on transmission. So we definitely saw that with significantly with influenza. I think the reason why we still saw a fair amount of SARS, even though we weren't seeing the influenza, so people were doing something to reduce the transmissions, is just because of the sheer number of people who are susceptible to SARS because it's a new virus. Interestingly, there's a virus called rhinovirus. That's the one that causes the common cold. And as soon as we came out of level 5, those levels of rhinovirus started to go up again. I know because I had it in May and felt pretty crummy. But it's a much hardier virus than the flu, and so it's less likely to be reduced with hand washing and things like that. And we've still seen that circulating at quite high levels. So, I think that SARS-CoV-2 is going to be a similar sort of transmission levels, but for now we're seeing more cases just because we've got so many more people who are susceptible because they've never had it before.
Does your blood type, your ethnic group, or your race has anything to do with the rate of infection? Because you say studies show that we can be in one room, but 2 to 3 people will contract the virus, not everyone. And have you looked at such figures to say, perhaps if you are blood group O, you are less likely to contract the virus, or certain race groups will get the COVID-19 more than other race groups quicker?
So there's some early studies looking at that. There'd been some suggestions around the blood group O, which I was quite excited about because I'm blood group O.
I would give you a high five right now, because me too.
But the problem with sort of looking at those genetic predispositions and things that can influence it is that there's so many factors that interplay that sometimes you might identify one thing that you think plays a role, but unless you're looking at all the data as a whole, or you're looking at diverse population groups, it can be difficult to say. So if it's done in one part of the world, looking at one specific population group, that may not necessarily translate to another population group. There has been a study recently published where they found that there's this Neanderthal gene that is found in Caucasians and parts of Asia from way back when the Neanderthals and the early humans, interbred in Europe, where they thought that might have a factor of why the Northern Hemisphere may be more severely impacted mortality-wise than the Southern Hemisphere. But, unless you start looking at diverse genetics and diverse populations, it's very difficult to pinpoint at this early stage what those protective factors might be.
Dr. Nyati, you made mention something very important, and that is the awareness of mental health. And especially in Africa, mental health is really not a priority. But one thing I am aware of is that when there's any uncertainty within any group, whether high LSM, lower LSM, no matter the creed or race, uncertainty causes anxiety.
Yes.
Uncertainty exasperates mental issues.
Yes.
Now, COVID-19, we are still sitting in limbo. There's so much uncertainty around the vaccine, around everything to do with COVID-19. In the workplace, in our individual lives, how do we then ensure that there is a priority that is given to mental health so that we don't see ourselves becoming that generation that had more people who suffered from the likes of depression, anxiety?
Yeah. You're quite right. Again, I mentioned the people in the workplace, they come from society. In China, in the early studies that was done around Feb, they picked up more than half of the people in that part of the world, they reported that they had, moderate to severe psychological impact as a result of the COVID-19 pandemic. Same in the US, same picture. And SADC here in South Africa, South African Depression and Anxiety Group, they did a study in April. It also confirmed that a majority of South Africans, were actually experiencing high levels of anxiety, symptoms, depression symptoms, and those with pre-existing, mental health challenges who were well controlled, they actually started to be out of control, okay? Take then from that society to the workplaces. In South Africa, the studies around the prevalence of mental health amongst employed South Africans, a study that was done in Stellenbosch in 2016 actually showed that about 25%, 1 in 4 South Africans who are working actually present with a mental illness. But what was even worse there was that of that 25%, only 25% actually do something about mental illness. The other 75% are walking wounded. I'll just put it that way, because they are worried that should they disclose or seek help, it might create a situation where they may not be promoted or they may be discriminated. There's a lot of stigma around mental health in South Africa. We even know a president not long ago who said, there's nothing called stress for black people, I'm sure some of you remember that.
Wow.
All right? So, but anyway, to come to your point, then the COVID-19 pandemic has actually worsened that psychological impact. So instead of the 1 in 4, we're now talking 1 in 3. So what should employers be doing? Employers should be putting in place employee support programs. There's something called employee assistance programs, where employees, as a result of working for company X, they've got access 24/7, 365 to counseling services from social workers and psychologists through a telephone line, nowadays even virtually, so that they can be able to seek that support. But the challenge is that most employers in South Africa are not putting those EAP programs in place. Big companies, blue chip companies, your standard banks and big IT companies, they've got those programs. But government departments, I'll talk in Gauteng, for example, they have got, let's say Department of Health. They've got some program, but it's not really, working well. It's supposed to be supporting all the healthcare workers. They've got a service provider they called Careways that provides that, for health and other departments. So I think what needs to happen is that organizations must put in place proper EAP programs, because the psychological impact, which affects productivity of the employees, they are present at work, but not productive, what they call, presentism. So we need to make sure that all employers, government, non-government, put in place these programs, because we are in this for a long haul. We've been saying or hearing that by 2030, we'll be seeing the highest impact of mental health challenges as the main reason for people to consult. That was pre-COVID. So with COVID now, we are seeing, increased need for those mental health services. Our outputs for psychiatrists is very, very, very low in South Africa. Like I said, 1,000 for 60 million population. And so we need to look at how technology can improve access to these kind of services, clinical psychologists and people like those. So that's really what needs to happen in South Africa. We need to put programs in place, and we must leverage technology so that we can ensure equity of access.
Dr. Nyati, yesterday we had Dr. Muwafe, who
Yes.
mentioned that when it comes to any industry,
Yes.
it is critical to ensure that we look after the young,
Yes.
we look after the youth.
Yes.
My question is, with mental wellness and health,
Yes.
why is there no focus when it comes to young people? Right now, majority of the people who are streaming in are probably students
Yeah.
and young professionals.
Yes.
We are aware that in South Africa, our grade 12 or matriculants are currently underway with their exams.
Yes.
I'm a mother. I know that my young ones, even in primary school, are part of exams now. It's been a stressful year for them.
It has been.
COVID-19 is not only stressing us adults, but it's stressing the kids more because obviously some parents have lost jobs,
Yeah.
the environment is not palatable at home, finances are not. So how can we also support our youngsters in the schooling environment, in the university environment? What programs should be implemented in a university like SMU to ensure that those who are practitioners within this within the mental health field are actually giving their services to young people?
Yeah. Well, let me start with the tertiary institutions, or what they call post-matric learning. Luckily, the Department of Higher Education, in South Africa, has got a unit called Higher Health under the leadership of Dr. Aluwalia. So in the middle of COVID, around May already, he rolled out a program that is supposed to be accessed by all people who are working, whether they are students or they are lecturers or head of departments, So that program is in place. There's a toll-free number that could then be used by anybody within that environment, to access these kind of services. And like I said, that was around May already, and it's been ongoing. But beyond that, they've also introduced other, technologies, for screening and also quick reporting if somebody, has got symptoms that could be pointing towards, COVID-19. So there is that, for the tertiary institutions. But for employers, I'll come to other employers now outside of the universities. These EAP programs are for the employee and immediate family members, all right? An average family in South Africa has got about 3 to 4 kids, these programs then, if you are working for an employer that's got that program, it's important to make sure that your children, teenagers, adolescents, they have got access to this. Because, and what I'm going to say may not necessarily be scientific, but there is a question around the emotional resilience of this latest generation of young people. We're seeing a lot of suicides amongst teenagers. We're seeing a lot of suicide amongst adolescents. And the question is, why are we seeing this? Has it got anything to do with our parenting? Other people are saying, well, the parents of today, have become much more of helicopter parents who are always there, and their children have never had the ability to really deal with life challenges. As a result, as they grow up and face life events, they are not so prepared to be able to deal with those things. So it's a question mark. I haven't read that from an academic, thingy. So the point, though, is we need to make available those support systems if you are lucky to work for an organization that's got an EAP program. But also, we need to kill the stigma around issues of mental health, and the younger the kids, the presentation may not be the normal depression presentation. So if you've got a teenager who sits at home and wants to close themselves in their room and they are moody and all of that, start thinking that there could be a problem. So we also need to be switched on as parents to see, when there are problems early before, we see, major challenges.
Professor Karim, we've heard that there are some antibody treatments that could be used as a stopgap while we are trying to establish if there's a vaccine that will be feasible or not. Do you think that these stopgap antibody treatments are still relevant, and can they be used in South Africa? Can we even afford them, given the fact of our current financial state in the country?
We had thought that antivirals would be effective because we've got a lot of experience with that from HIV. Unfortunately, those results were somewhat disappointing, particularly using drugs like the lopinavir. So now we know that one particular antiviral called remdesivir is effective against this virus, but its benefits are quite modest in that it seems that its main impact is a reduction in the number of hospital days. But it doesn't seem to be impacting on mortality, which is quite important, especially because the drug has to be given as an injectable and is a 5-day course that is not cheap. So at this stage, it doesn't look like that particular antiviral has benefits that outweigh its costs. Now there's a new stream of antibodies that are becoming available. Regeneron is one of them. Eli Lilly has some, and there have been several new ones also becoming available. The challenge with antibodies, especially monoclonals, is that they're quite expensive to make. They're not cheap at all. And so when you think about the amount of time and effort that goes into making these antibodies and then providing them, it's an expensive business. However, it's left to be seen as to what the benefits are. So we know the costs are going to be high. The benefits are unclear. And the benefits are unclear because there aren't really good randomized controlled trials, either of convalescent serum or of monoclonal antibodies. And this is really an unfortunate situation because these drugs have been widely used in the context of just care provision as opposed to undertaking randomized controlled trials. So it's left to be seen whether there is any direct benefit in terms of decreasing severity and a survival benefit from antibodies before we can make any judgments about whether it's something we really want to proceed with. But I think at the end of the day, right now, all eyes are on the randomized controlled trials that are studying various vaccines, because that, of course, has a very substantial benefit if it is protective. And certainly the early results indicate that that is the case. So I think at this stage, it's, I would say it's premature for us to be talking about making these antibodies available as for therapeutic purposes.
As we are about to wrap up, I'd like to just get parting shots, and perhaps let's start with you, Professor Karim. What are your parting shots around the panel discussion that we have had, and to encourage everyone who's viewing and joining us on this 50th annual IADR conference? What is it that you can encourage us with?
So I think we have to understand that we are now in a one world situation between pathogens that impact animals and pathogens that impact humans. We have already seen that if you take the last 5 years, there have been over 36 different epidemics in Africa. Whether they're viruses or bacteria. For example, we've had listeriosis, we've had an outbreak of measles. So across the continent, we routinely get these kinds of epidemics. So we have to be in a situation going forward where we are better prepared. We have the surveillance systems in place, we have the care models in place, and we have the disaster planning in place, especially for a disease that's highly infectious like coronavirus. So my parting comments is that being prepared is a lot more important than being reactive to a pending pandemic and the future pandemics that we are likely to see.
Thank you very much, Professor Karim, and definitely I do agree with you there. My sentiments are the same. Let us be prepared all the time. After all, prevention is better than cure. So let's be on that note. And as we close off, Dr. Glass, actually, I didn't even compliment you. Please forgive me. Dr. Glass is looking so amazing. For someone who works in a pathology lab, I'm sure it must be a breeze to be out of the suit you're always wearing.
It was great. Great to have an opportunity to dress up and come and see other people for a change.
Well, and pathology is one of those professions that we hardly ever see pathologists because you're always locked up and you're always in gloves and, you know, all covered up. And yeah, you're looking beautiful.
Thank
and
you.
thank you very much. Give us your parting shots and some encouragement to especially those who are tuned in as professionals within the dentistry field to say what is it that we should be expecting and the support that we can give to you as pathologists and support that you can give to them within this industry.
So my parting comment, and it was something that I thought about, just talking about the mental health, and I think it's the mental health of us as colleagues. Is it's, you know, this has been a traumatic time for us, and I think one of the things I would like to, on a completely unscientific note, is to say, let us be kinder to each other and understand that we're all under a lot of pressure. You're under the pressure to be able to do your job, and sometimes that requires a lab result, and we're under pressure to provide those lab results, and often, you know, that creates this very stressful environment for everybody. But I think if colleagues can learn to be kind to each other and supportive of each other, and then just to remember that, as I said, those basic preventative measures that, you know, we encourage, of the face masks, the hand washing, you know, they do work to reduce the spread of infectious diseases. So would encourage you to continue to be diligent with those.
Thank you very much, Dr. Glass. And lastly, but definitely not least, Dr. Nyati, I'd like you to please give us your parting shots. And I'm sure in those parting shots, you are not only going to talk to us and professionals, but you're also going to talk to the entire employee-employer, you know, field and relationship, because it's quite important that we understand that that is the economic driving force of our country.
Yes. Thank you. Well, yeah, my parting shot, I think, to South Africans out there is that, you know, when this pandemic started, everybody expected that, you know, it's going to be a problem in South Africa, a major, major problem. We already had, you know, the 7 million plus of people who are HIV positive in this country. And so if those people get infected with COVID-19, we're just going to see numbers of deaths that, you know, are unprecedented. But you know what? We've had, we're now number 13 in the world, 744K in terms of the number of people who have been infected. But in terms of the death rate, we're just around 2.6. Obviously, every death is regrettable. But to have 2.7% of deaths, you know, in the country, for me, that is very, very, very good compared to other countries like in the US and Italy with much higher levels. So I keep on saying, you know, South Africa, sometimes we have a way of doing well when everybody else expects us to actually do badly. And we are much better prepared now for pandemics than we did before. I'm happy, you know, countries like, agencies like CSIR and others are now putting in place, you know, measures to develop, you know, equipment so that we can be better, you know, self-sufficient. All right. So I'm happy with that. Also, as far as vaccines are concerned, I'm happy also to hear that some South African companies like Aspen, you know, are already in talks with some of the global companies to manufacture, you know, vaccines should they get the approvals. That's good, you know, because other countries in the continent don't have that capacity. So we need to look on the brighter side. Yes, we've lost compatriots, and it's regrettable. We've lost healthcare workers. We've lost people that we work with. You know, those are martyrs in the fight against this pandemic. But we must still be positive about the fact that, you know, it's possible to win, you know, this fight against the pandemic. And the minister earlier talked about the NHI. I'm one of the proponents, you know, people who support the universal healthcare system in this country, but I also have been one of those people who are skeptical about the ability to roll it out, looking at the pilot, you know, processes, you know, or the pilots that happened about 5 years ago that did not really achieve much. So the issue of corruption for me is my biggest worry now, because we're looking at NHI in 2026. How are we going to make sure that the kind of corruption we have seen with COVID-19 does not take place? You know, when we have a mega SOE that will be called NHI Fund. So I'm looking forward to it, but I'm also apprehensive about, you know, the level of corruption in this country. And that 9-point plan by the minister in terms of revitalizing our healthcare system, I think now more than ever, it's much, much more needed.
Thank you so very much to all the panelists of this session. That was Professor Karim, and we also had Dr. Glass and Dr. Nyati. We are going to get the pleasure of giving all our guests, speakers right now, a gift. May I please welcome on to the platform Professor Hendricks, who is the CEO and Dean. And then after that, I'll let you know what's going to be happening. I'm sure you're going to be happy with me with the news I'm about to tell you. Ah, Dr. Nyati is hungry. Yes, it is going to be food, Dr. Nyati. It is going to be food.
Thank you. Thank you. Okay, thank you very much. Okay.
Thank you to all our panelists, and this session is now going to be closed, as preempted by Makosi Dr. Nyati, who's officially our glass ball reader. It's time for us to have lunch. We're going to have an hour's lunch break, and we'll be back at 2 o'clock. But just so that you know that it is worthy and, you know, very important for you to come back after the lunch break, let me tell you who's going to be speaking to us. We are going to have a very exciting talk about Professor Mtawung. Professor Mtawung is going to be talking about the perspective of tissue engineering and regenerative medicine in COVID-19. Very, very important topic to tune into. And then after that, we'll have Dr. Pablo Vargas, all the way from Brazil, who's going to be giving us a remote teaching for dental students during COVID-19 pandemic, and obviously from the Brazilian experience and point of view. Dr. Hilda Minajo is from SMU, and she'll be talking to us about medical law and bioethics. Yesterday, we were quite keen to know around ethics. So today, we will have a talk about that, and we'll have a lot of other speakers who are going to be joining us. So make sure that you do come back. Exactly an hour from now, we will be back. And remember, for those WhatsApp questions and comments, please send them to 064 656 0131. Or you can also make sure that you forward this link to all your friends, family members, put it on your status so everyone else can log in to get the information. www.smu.ac.za/IADR/2020.
Janet. Janet is the manager at a really busy dental practice. Her boss, Dr. Jones, wants her to improve the productivity and profitability of the practice. She's already working to the max. What Janet really needs is an easy-to-use online ordering system that really simplifies her day-to-day ordering process. Luckily for Janet, there's a better way. Introducing My Right Place. At Wright Milners, we've always worked hard to offer you the very best value for your money. And now we're really excited to be able to offer you the very latest smart solution. Okay, here's how it works. A Wright Milners representative will come to your practice and help you set up and personalize My Right Place. We'll help you set up individual users and you can tell us their budget. Make your very own bespoke catalogue using your preferred products and brands. That's it, you're ready to go. Simply log on to our website and start saving. With just a few clicks of the mouse, you'll be able to compare your practice's overall spend, not only month by month and week by week, but you'll also be able to drill down and compare individual practitioners' spending habits. My Right Place is intuitive, simple to customize, and will allow you to see real-time savings for both you and your practice. So let's summarize. My Right Place. It's simple to set up and manage. It's easy to set up individual spending limits. And you can create your own bespoke catalogues. My Right Place from Wright Milners.
I was doing the full edentulous upper and lower for a patient, and my reference was the registration that I got from a dentist. So I've put in all the teeth are 28, and then now I'm going to do a wax up, and then I'm going to polish it nicely so that it can be ready to.
The diagnosis that we come to will then help with producing the correct treatment for the patient, and will also determine what is the prognosis of the treatment. And thank you so much for watching.
So this shows the impressions made as you can see in a lab in the form of a study model. So it's very quick, as you can see, and we can view it in all aspects, like how we can do for the study model. You can see the buccal, the labial, the occlusal aspect, and also the lingual aspect. That's the legal aspect as well. So it's very good in the sense that a lot of time is saved and costs as well. Thank you.
You are currently in the Department of Oral Pathology. We are analyzing tissue samples that the surgeons send us from theatre, from patients who have any cancerous or non-cancerous lesions. I am part of the technical team, which uses a microtome to make thin sections of tissue samples embedded in paraffin wax. Then we will use the exact band saw. It's got a diamond blade that will cut bony tissue.
evolutionary process going on. But mankind won't be destroyed. The fact that you and I are working here today is evidence of that.
Hi, my name is Bradley Bredekamp. I'm a periodontist practicing out of Durban, and today we're going to show you a brief video on the placement of the Megagen AnyRidge implant system. Okay, so today's site is a 4-5 site that we're going to replace. There was a recent extraction done, which you'll see on the periapical x-ray. And we're going to start with our crystal incision, which we make just palatal or lingual of the midline. And it's a full thickness flap that we're doing, and then sulcular incisions along the adjacent teeth. Once we've done the incisions, we start reflecting from the line angles, and we go down to bone and just reflect gently, easily and distally. Once we've done that, we take tissue holding forceps, we grab the tissue with it, and we gently reflect, not applying force. Always holding the tissue and then reflecting. We reflect so that we can see the buccal shelf of the ridge, and then we reflect till we see the lingual. Good visibility is of critical importance. Once we've done that, I take a Boozer bone scraper, and I usually just clean the soft tissue tags off the crestal tissue just to give me better visibility of the ridge. Once we've done that, we're going to commence our drilling protocol. So the first drill we use is our lance drill, and the purpose of this drill is just to perforate the cortical plate. The next drills we use are the pilot drills. As you can see, we start off with the 7mm. The beauty of the Megagen drills, which some others also have, is these stoppers. When we start drilling, we will go in with a pump action, and that is so we clear the bone that's coming off there, and we're not generating too much heat. So in a pump action, we go up and down till we get to the depth of the drill. Now I have determined beforehand from my cone beam and my periapical planning what the length of implant will be. So I can up and down till I get to the depth. Once we reach the depth, we will then take our paralleling pin, the lowest being 7 mils, then 10 mils, then 13 millimeters. As we can see from the radiographic picture, we still have good distance from the mental foramen here. So we go on to our next drill, which is the 8.5 drill, or the drill for the 8.5 implant, which you can see with a number 8 at the end of the shaft, on the shaft of the drill. This bone is type 1 bone, very hard, so critical to go with the pump action. So we get to the depth. Okay, so my plan is to place an 8.5 length, but with these type of implants, you want to place them subcrestally. So we will actually drill beyond the length we want to, even though these drills do take that into account. So I'm going to use the 10 mil drill, and we use our next in the sequence of drills, which is actually the 2.8 drill. And once again, this drill in the Megagen kit also comes with the stoppers. So it's not just the pilot drill, which the other systems that have stoppers do, they even go up to the core drill. So then we go to our core drill, which is a 3.3 drill. So this correlates with the size of the implant we're going to place, always still ensuring that my water is hitting the drill and cooling the drill. See the bone bits that come out of the drill? That's why the pump action. So now we move to our profile drill, and we're going to place a 4.5 diameter implant. So we go with the profile drill first at the reduced speed, and we go now the full length of the profile drill is 8 millimeters. Okay, so we're taking the 4 profile drill because we're going to place a 4 for 8.5. So you can see this implant's got an enhanced surface because it has that denimish grey color to it. And now we're going to set our speed to the placement, 45 torque and 30 RPMs to place the implant in. But it may stop too soon, in which case we will then reverse it out and prepare a little bit more. So that's torqued out. The torque wrench with a hand wrench, and we're going to torque it down with this, just assessing how tight it is. But we mustn't feel too much pressure. It's already at 45 and it's not synced. I want it to be 2 millimeters below. I'm going to reverse the implant out completely, and this is all fine to do. Okay, we'll put it back in the carrier, trying not to touch the sides, and remove that. So what I now do is I will go one drill up from the 3.3, which was the core drill, which is the 3.8 drill. As you can see, So 10 millimeters is the bottom of that broad band, most apical. So I'm going to drill just before that. Lots of irrigation, pumping action. And if you're not sure, you can take the drill out. We put it in the site, take a periapical. And the nice thing with these drills is you can actually see the markings by notches on the drill. So we've got our 3.8 drill again. I'm going to take my profile drill again, making sure to choose the right one. And now we will try and seat our implant again. There's the implant. And now we can see that implant sinking below the crest of the bone. And it bottoms out, as you can hear at the talk. But you can already see it's subcrestal. Turn it in a little bit more. So now I can go with my torque wrench and I turn it in. Now you'll feel it starts biting tighter. Remember, bone is a living tissue and it needs to stretch, so we will reverse it a little bit because we don't want too much pressure on the bone, otherwise we get necrosis. So a few turns to reverse and then we go in again. But you'll see, even if I do this, I'm not sacrificing my primary stability. I will still end up with quite high primary stability. Don't overturn it though, because then you will struggle to get this thing to unscrew. And that's usually when you strip the stuff. Although with a Megagen, it's quite resistant to that. So we turn it in, so the flat surface buckle. I've got over 45 newtons of insertion torque arm. I will take the implant out. Now we take an x-ray. So there's the crest of the bone. The implant is 2 mils below. There is the mental foramen, and we've got at least a 3 millimeter safety zone. These are called pathfinders. Screw them in. I can see my distances from the teeth. So we can see we've got enough for primary prosthetic space. We still have 3 millimeters. Now then the ISQ, which we mentioned earlier. Before you insert the smart peg with your sterile water, that you just rinse out the inner well of the implant, and you can see it's 78, 79. So now we've got to choose our healing abutment. Here we're using a 5 diameter and a height of 4 millimeters. So that's the healing abutment. We put a little bit of chlorhexidine gel on there, an allogel. I first just finger tighten to feel if it seats properly. On the x-ray you can see that's the healing abutment. Notice how there's a gap between the healing abutment and the bone, and that there must be no space between the implant surface top here of the implant and the healing abutment. Otherwise it's not seated properly. With finger pressure, tie and turn it till it stops. Once I've done that, I take my torque wrench, using it on the mobile arm, and I torque it to about 35 Newton centimeters, spring loaded with the arm. And we're going to do a Palachi. I can't get this opposed as nicely there because the tissue's in the way. So we're just going to mobilize this tissue. In line with the mesial end of the healing abutment, we make a 2 millimeter deep incision, and then we go across for the diameter of the healing abutment. And that allows me to mobilize that piece of tissue distally and a bit tissue easily. And then we use our 6-0 non-resorb monofilament sutures because we're wanting to reduce the inflammation and we don't want to strangulate the tissue. So we go through the first thing, always grabbing in the middle of the shaft of the needle, not at the swage or at the tip. Go through the one part of the tissue first, the buccal part of the flap. Don't try and go through all the way. Then engage the second part. And these sutures can't be under high tension, they're passive, or they will snap, which is another reason why we use them. We don't want too much tension on the tissue. The only time I use a braided suture here is if it's a patient with bleeding disorders and I need to have more compression on the site. These are not dissolving, so 10 days later we need to remove the sutures. Wipe it down with the Hibitane solution over the top to make sure we clean it nicely. And irrigate the area. The important thing I want to show you is, you see how nice and passive that is? See how the widest part of the stud is below the margin of the tissue. It's not standing above the margin of the tissue. That is actually critical when you're doing these, because otherwise you're not going to be able to get the right emergence profile for this situation.
When you look at laser dentistry, which I think is important, why we went into the oral healthcare profession, it's got to work, meaning that we do need clinical outcomes. What if I provide something that's able to at least decrease pain, but sometimes even pain-free? If you have periodontal laser procedures, you're taking an ibuprofen. You're getting up the next day. Patients are going to want laser for dentistry. They realize that they're going to have minimal discomfort. It's going to be faster than other procedures. I highly recommend, if you want to be successful for the next 5 years, you've got to start doing minimally invasive dentistry.
Meet Janet. Janet is the manager at a really busy dental practice. Her boss, Dr. Jones, wants her to improve the productivity and profitability of the practice. She's already working to the max. What Janet really needs is an easy-to-use online ordering system that really simplifies her day-to-day ordering process. Luckily for Janet, there's a better way. Introducing My Right Place. At Wright Milners, we've always worked hard to offer you the very best value for your money. And now we're really excited to be able to offer you the very latest smart solution. Okay, here's how it works. A Wright Milners representative will come to your practice and help you set up and personalize My Right Place. We'll help you set up individual users and you can tell us their budget. Make your very own bespoke catalog using your preferred products and brands. That's it, you're ready to go. Simply log on to our website and start saving. With just a few clicks of the mouse, you'll be able to compare your practice's overall spend, not only month by month and week by week, but you'll also be able to drill down and compare individual practitioners' spending habits. My Right Place is intuitive, simple to customize, and will allow you to see real-time savings for both you and your practice. So let's summarize. My Right Place. It's simple to set up and manage. It's easy to set up individual spending limits. And you can create your own bespoke catalogs. My Right Place from Wright Milners.
I was doing the full edentulous upper and lower for a patient, and my reference was the registration that I got from a dentist. So I've put in all the teeth. The teeth are 28, and then now I'm going to do a wax up, and then I'm going to polish it nicely so that it can be ready to.
The diagnosis that we come to will then help with producing the correct treatment for the patient, and will also determine what is the prognosis of the treatment. And thank you so much for watching.
So this shows the impressions made as you can see in a lab in the form of a study model. So it's very quick, as you can see, and we can view it in all aspects, like how we can do for the study model. You can see the buccal, the labial, the occlusal aspect, and also the lingual aspect. Let me see there you go, that's the lingual aspect as well. So it's very good in the sense that a lot of time is saved and costs as well. Thank you.
You are currently in the Department of Oral Pathology. We are analyzing tissue samples that the surgeons send us from theatre, from patients who have any cancerous or non-cancerous lesions. I am part of the technical team, which uses a microtome to make thin sections of tissue samples embedded in paraffin wax. Then we will use the exact band saw. It's got a diamond blade that will cut bony tissue for
but mankind won't be destroyed. The fact that you and I are working here today is evidence of that.
Welcome back. This is the second day of the 50th International Association Dental Research, IADR Congress, and we are hosted by SMU in South Africa, Pretoria, and our venue is the Pretoria Fire and Ice Hotel. We are really eager to make sure that the last half of this particular program is going to be one that you will remember and you will gain a lot of experience from. My name is Patricia Ntuli, and I am your host until the end of today's Congress. I'm so excited to be part of this beautiful, game-changing, innovative online Congress, the 50th Congress of the IADR. Let me remind you that today, at this juncture, we are going to be talking to a couple of speakers. One will be talking about the perspective of tissue engineering and regenerative medicine in COVID-19. We'll also be looking at remote teaching for dental students during COVID-19, and we'll get the Brazilian perspective of this particular remote teaching. We'll have the opportunity to hear more about medical law and bioethics, and we'll also have an address from one of our deputy ministers. So make sure that you are tuned in. Forward it to your friends, family, colleagues, and everyone that you feel has an interest within this industry, this particular website, so that they can be able to click on the link, and once they've clicked on the link, they'll be able to join us. The link is www.smu.ac.za/IADR/2020. We also have a WhatsApp line, and on that WhatsApp line, I'd like you to send your questions to our panelists, or even send comments about the wealth of knowledge that you have received from this Congress since we started yesterday. The WhatsApp number is 064 656 0131. Without further ado, I'd like us to warmly welcome, and this is going to be via Zoom, Professor K.S. Mtawung. Professor K.S. Mtawung is a founder and chief executive of Global Health Biotech, and she is a professor, but not only that, she does research science and is also an entrepreneur. She trains her postgrad students not just to It seems we're having technical difficulties due to the connection, and my technical team is just letting me know that we are definitely going to continue. Let me continue giving you a brief on Professor Mtawung's brief bio on her. She trains her postgrad students on not just how to research, but also how to become scientists who also become entrepreneurs. And I think in this day and age where jobs are scarce and opportunities are far and few in between, it is a good thing that qualified scientists are taught how to become their own job creators and entrepreneurs themselves. After completing their studies, what she does is encourages young people who are within the science field to not look just for jobs, but to be job creators. Professor Mtawung is passionate about capacity building and has trained 16 postgraduate students, 13 of which were masters and 3 were doctoral. She's currently supervising 4 doctorate students and 4 master's students. So she's one busy lady, and we are definitely going to have a wealth of information when we interact with her a bit later via Zoom. If you have questions on how to become a scientist/entrepreneur for Professor Mtawung, please do let us know via WhatsApp, which is 064 656 03131. After that, we'll be talking to Dr. Pablo Vargas. Dr. Pablo Vargas now is going to be with us via video, and I think this is one of those very important elements of this profession in this day and age. How has learning continued despite the lockdown worldwide, despite the challenge of the change in which teaching has been done? Dr. Pablo Vargas is a dental graduate of the UNESP in Brazil and obtained his Master's of Science in and PhD titles in oral pathology at UNICAP in Brazil. He worked as honorary senior lecturer of the Department of Oral Pathology of the University of Sheffield in the UK between 2005 and 2007, and is a fellow of Royal College of Pathologists in the UK from 2013 to date. So clearly he's got a Southern American experience and knowledge when it comes to dentistry, and also European knowledge. We are definitely going to be able to glean a lot of knowledge from Dr. Vargas a bit later on. He'll be talking about remote teaching for dental students during COVID-19 pandemic. Let's go to a bit of a break, and then hopefully by then we will have Professor Mtawung via Zoom. We thank you for your patience, and as we know, 4IR requires a lot of things from all of us. So patience is one of those elements that are needed. And this is technology we're talking about here. Connectivity is sometimes an issue, but thank goodness that at least we managed to get hold of Professor Mtaung, who will be giving us her perspective of tissue engineering and regenerative medicine in COVID-19. Remember that this is the centenary celebration, the 50th International Association Dental Research Congress, and we would like you to please interact with us and ask your questions via WhatsApp. The number is 064 656 0131. Thank you very much for joining us, Professor Mtaung. How are you this afternoon?
I'm good, and how about you?
We are well, thank you. I'm glad that you can hear us loud and clearly. Professor, we are aware that you're going to be giving us a brilliant presentation around the perspective of tissue engineering and regenerative medicine in COVID-19.
Yes, ma'am. This is what I'm just going to give a talk about, the perspective of tissue engineering and regenerative medicine and COVID-19 using medicinal plants.
Professor, over to you. Over to you.
Okay, thank you so much, and thank you for inviting me. Let me take this opportunity to thank the organizer for inviting me. I'm so excited to come and share with them what I have done, my experience in terms of tissue engineering and regenerative medicine. Without any waste of time, as you have already introduced myself, my name is Kiolebohile Mutaung. I'm the founder and CEO of Global Health Biotech, which is the spin-off company coming from my research background. And this is how my talk is just going to be in a nutshell, the introduction and looking at the economy of South Africa after COVID-19 and what are the key ingredients of tissue engineering, what is the definition of tissue engineering, principle and the impact, and what are the challenges. Now, I would love to start my presentation with this gentleman who the name is Albert Einstein, always said, if I were given 1 hour to save a planet, I would spend 59 minutes defining the problem and 1 minute resolving it. And then now, this is all started in March 2020 when the first case was reported, when the first case of COVID-19 was reported. Then, according to WHO, it was on the 9th of April, where there was already about 1.5 million patients worldwide that was already been diagnosed with COVID-19, which was caused by a laboratory confirmed infection of the SARS-CoV-2. Now, what is happening now? Currently, hospital systems, they are rapidly filling with patients suffering from viral illness, and the capacity of resources such as emergency department, inpatient wards, ICU has become overwhelmed in some region in a manner that if you also go to the ICU, the orthopedic surgeons, they can't even perform knee replacement because of this whole overwhelmed of the ward. There is a need for a new diagnostic and therapeutic modality. In terms of the diagnosis, early diagnosis for COVID is critical in establishing the quarantine and limiting the spread of outbreaks. And we all know this is the challenge with the COVID-19 in terms of the diagnosis early. Diagnostic later in the course of the epidemic remain important, particularly in determining the established immunity. And we can talk about that. That's also becoming a challenge in terms of whether can one test the antibody to be able to confirm. Let's go back home and see where we are. If you look at South Africa and look at Africa, has a unique demographic challenges, and COVID-19 and countermeasures need to be appropriate, effective, and safe. And again, due to the human and culinary diversity of the population, South Africa is rich in native flora that is currently tapped as medicine by traditional healers. And currently, so far, however, little is known about these natural products of our native flora and their potential to serve as a remedy for COVID-19. Work still needs to be done. So what is needed? We need to explore our native flora of South Africa as a source of novel biomarkers for treating COVID-19. And also, we need to evaluate the purified natural products from this plant species for the treatment of COVID-19 and other related conditions. Remember, most of the drugs that we always use, they are coming, those Western drugs that we use, they come from medicinal plants. The short-term motivation is to respond to the urgent need for a solution against COVID-19. And the long-term, which everybody is now busy doing, is to develop a vaccine or either a supplement or a drug from this plant root extract that will treat COVID-19. The economy of Africa and the ability as a country to compete in the global market depends on the needs of more enterprise and innovation. And hence, we talk about fourth IR, we talk about tissue engineering, regenerative medicine, stem cell, which also form part of IR. We talk about innovation that is also needed in terms of that. Research needs to be going on in terms of doing research. University education is becoming progressively diverse with a greater emphasis on the whole experience, not only on the academic side of things. We have to keep on changing. If we not, technology keep on changing. We need to do research that is also going to be translated. We need to do research that is going to have an impact in the community. When are those days when we are doing a blue sky research, we don't have that time anymore. COVID has shown us that it's about time that we do something that is going to be translated. The multidisciplinary work and the culture of collaboration is becoming the norm, with the average student being more exposed to innovative thinking. And we need to make sure that the researchers should develop research plan and target design to systematically address risk and address value proposition. Hence, tissue engineering, regenerative medicine is uniquely suited to offer solution to this complex clinical question. Hence, I'm proposing tissue engineering. Tissue engineering-based technology are being developed to revolutionize areas in medicine, such as drug discovery, personalized cancer therapy, and just mentioning few, immune modulation and organ transplantation. And hence, I'm so excited when I talk about tissue engineering. Now, if somebody asks me, I'm just giving you that an introduction. What is tissue engineering? How you define it? This is a science of design and manufacture of new tissue for the functional restoration of impaired organs and replacement of lost parts due to cancer, disease, and trauma. Then you go back and start to define this in a layman's term, where somebody asks you, what is really tissue engineering? And I usually said, it's nothing else but is a creation of human spare parts, not trying to play God. Now, what are we trying to create in case of the COVID? We all know one of the organs that is going to be affected is mainly the lung. And again, when you're also looking back in terms of the organ transplantation, nobody actually wants to donate their organ. And if so, we've also got other challenges. Some is the cultural beliefs, some is the traditional beliefs that one doesn't want to donate their organ. Hence, tissue engineering and regenerative medicine is going to solve this problem. What are those key ingredients? If we really want to make sure that we're going to regenerate a lung that has already been damaged due to COVID, this is where you're gonna need your morphogenetic signal. In this case, is where one is going to use medicinal plants, because I have already done a lot of research with medicinal plants. I've seen that, I've even developed a product from medicinal plants. And then what are you also going to need? You need responding stem cell. And what are you also going to need? You need the extra matrix scaffold, which is gonna carry the cells. And then how you do this? Very simple. This is, I love the principle of tissue engineering. When you take your signal, in this case, it's a medicinal plant. It can be a compound coming from medicinal plants if you have isolated it, a purified coming from medicinal if you have. And then you take a scaffold, which is a carrier. and we add your stem cell, you get an organ, and that is a lung. And this is not only for that, it can also happen that when you take, it's just the principle, you take the signal, it can be a transforming growth factor, it can be a BMP, bone morphogenetic factor, it can be a medicinal plant, it can be any kind of a compound. And then you add the scaffold that you're going to use, and then you add your stem cell. This is what you're going to get. You're going to get a lung or an organ. It depends what you'll be looking at. Now, tissue engineering emphasizes clinical translational, including creating workflows to optimize bringing the bench top to the bench side. And as I was talking about that, one of those days that we used to do research for the sake of doing research. And in the current setting, it's limited clinical data and rising patient mobility and mortality, tissue engineering will be welcome and valuable unless in the COVID-19. And since the virus is primarily affecting the lungs. These are all areas in which tissue engineers are primed to make significant contribution for COVID-19, the next coronavirus epidemic, or other future viral outbreaks. So what I'm trying to explain here is to show that we do have a solution in an African context, but it's just, we know how to do that, but it's now, how are we going to step into that to be able to follow that? In most cases, this is a case study. Whenever we do this, we always have to start from the lab. And it's either going to be an in vitro from the in vitro and in vivo from in vivo, it becomes an animal model. Now, the development in vitro model of viral disease can assist in two critical roles during the pandemic. Hence, you cannot just take something and go straight to the patient or to the people without testing it. One needs to do the following: better characterization and understanding of the host pathogen, interface, and mechanism of infection. And how one is going to do that. All these things, they need to be manipulated in the laboratory before you can take them out there. Because whenever you're going to do any clinical trial, they're always going to ask you, how did you handle the in vivo and the in vitro study? And then also, it's also going to serve as a platform for high throughput screening of potential therapeutics. Currently, it is challenging and clinically necessary to predict the cause of patient infected with the COVID-19. Hence, it is very important always to go and study this model in the in vitro. One of the things that has always been the challenging was in terms of the biomarkers for this virus. Profiling biomarkers may allow for better risk stratification and resource alignment. And this is one of the challenges where, as a medical scientist, by the way, my profession, we actually don't have a specific marker that one can say this marker. If you want to diagnose COVID, you are going to say this is the marker. And hence, we talk about the profiling, a lot of biomarkers may be able to assist for us for better risk stratification. On the other hand, more accurate in vitro modeling to understand the host response as well as viral mechanism for transmission and replication is critical for the identification of biomarkers to pursue as hypothesis-driven diagnostic and therapeutic target. Hence, we talk about biomarkers, hence we always talk about it is very crucial. For each and every disease that one has to study, you need to understand what are the biomarkers relating that. In vitro model has the potential to fill the critical need for improved drug candidate screening, and the current gold standard for screening the antiviral therapeutics is based on the statistic monolayer of aerosols. And most of the time, whenever you're going to develop any drug, you'll have to start from the in vitro, from the cell, from the lab. And then in this case, this is where they've used the virocell to study this model. And then why are they using the virocell, not any other? Virocells were exposed to a library of 3,000 drugs, which was approved by the food FDA. And then on the other hand, why as well virocell? The virocells lack interferon. They are highly susceptible to viruses and allow for replication. And so they have been an attractive vehicle to screen compounds. Hence, if you're going to do a vaccine, hence we have to start using all these virocells based on their properties. However, the interferon itself is an important regulator of host bringing protein involved in the SARS-CoV-19, in the COVID-19. So hence I'm talking about the viruses is to show that we do have the solution, that we just have to start learning this in the lab, that one can end up coming with the solution for COVID-19. Tissue engineering has made significant advances regarding the in vitro human cell culture model, such as development of induced polyprotein stem cell, the 3D printing, and biomaterials. And I can go on tissue engineering, the significant impact that has already been done, has already been proven. That is the way to go if we really want to come with a new technique. And if we talk about the fourth IR as well, that we cannot be left behind with regenerative medicine. In conclusion, I would like to conclude by saying the rate of infection and mortality, the rate of infection and mortality from COVID-19 make it unlikely any virus in this century. It's about time. And this is one of the things that I have learned, especially with COVID. It has humbled a lot of people. It used to be difficult for the scientists to work with the clinician. The clinician, they will work there on their own, and the scientists, they will be there on their own. Based on my experience, ever since now we start doing this, it was really humbled us, as I would always say, COVID has humbled a lot of people. That the very same physician and scientists are bending together to combat the threat of SARS-CoV-2. I can talk about the experience that we had a group from Sefako group from VITS and us, medical scientists, that we were really working together as a team to look at one thing, because we want to come with a solution or the treatment for COVID-19. And it has never happened before where you see the biomedical scientists working with the clinician. Everybody used to think that they are working on their own there. That collaboration effort has never been there. That is one of the things that one has learned. Tissue engineers have a rare set of tools and can make substantial contribution to our understanding of viral diseases and contribute toward the clinical development of diagnostic and therapeutic platform. Together, we can overcome this current pandemic and work to prevent and mitigate future viral outbreaks. So what I'm trying to say, why I propose the perspective of tissue engineering for COVID-19, I want to make sure that we've got a solution. It's just as scientists, clinicians, to start working together where we can come with a better solution. If we have already done that with the bone and cartilage regeneration, I don't think it's also going to be difficult to be able to do what we wanted to do in terms of COVID-19. Hence, in conclusion, I can just say that perspective of tissue engineering and of tissue engineering and regenerative medicine and COVID-19 using medicinal plants, I've already started with the pilot study where one can start seeing how these medicinal plants are really behaving when you treat them, the positive sample in terms of using medicinal plants. So hence I'm proud to say that there is a need for collaboration work, and then tissue engineering has got a solution to come with a new technique where we'll be able to diagnose, number one, and after that, to be able to cure COVID-19 using tissue engineering and regenerative medicine. So I just want to come in conclusion to say, I thank you and thank you for inviting me. And this is, if you need more information regarding what I'm doing, where I am, regarding the COVID, you can just log into my website there and all the information will be there. And that, I just want to thank you so much for inviting me. Thank you.
Thank you very much, Professor Mtaung. I think I've really taken a couple of notes from what you have given us as a presentation. And I'd like to go through a couple of questions with you. You make mention that development of diagnostic and therapeutic measures has been put to the forefront since COVID-19. Have there been a lot of collaborations?
For now, let me talk. Thank you so much for that question. In terms of collaboration, there's been a lot of collaboration for now based on who am I collaborating. I've got a group from SMU who I'm collaborating with, and the group from Wits University who I'm collaborating with. And what I like about that, we've got the people, and again, I'm glad because some of them, they are from the Department of Dentistry, Dental Techno Dentist, I can put it in that way, that we are working together. And then we've also got the vascular surgeons that we were all working together, including the public health people from the public health that we are also working together, including myself being the biomedical scientist. So clearly it seems that there is that kind of a collaboration and we can start working together as a team. But this is for the first time in my experience where one could see everyone coming from different angles and having one common thing that we want to work together as a team. So we are on the right track. And again, thanks, I guess it's because of COVID, because it has never happened based on my experience in terms of my research.
That means definitely there'll be a lot of development around tissue engineering and regenerative medicine. Another thing that you spoke about, and I think it really touched my heart as a traditional healer or traditional practitioner myself, the fact that native flora needs to be tapped into to find solutions for COVID-19. And I'm sure not only for COVID-19, but how do you propose that this will be done? Because at the end of the day, we are aware that all medication, in order for it to be recognized worldwide, it needs to be tested. But in terms of native medication, okay, go ahead.
Yes.
Go ahead, Professor.
No, I'm listening. Oh, I lost it at the, sometimes. You mentioned that I lost it when you were saying you were a traditional healer, and then some of the medical medicine needs to be tested, and that's what I wanted to get to what you wanted to say so that I can follow it nicely there.
Okay. Can you hear us clearly now?
Yes.
Okay, so the question was, in
Yes, I can hear you
terms
now.
of a native flora that you mentioned,
yes,
we are aware
yes.
that in African traditional practice, we are so used to using our natural flora, but in order for it to be accepted worldwide, it would need to be tested, especially for COVID and the likes. So how do you suggest that these tests could be done in a way that will not disenfranchise the traditional healers?
Thank you so much for that question. It's because I'm already working towards that actually in my lab. What needs to happen in terms of the native flora or traditional medicine, before you can do any claims, they need to be tested, the safety and efficacy need to be tested in the lab. And then so that you don't just go and say something that you know that it has not been tested. And then after you have tested that in the lab, there must be an evidence that you have really proven that it can cure or it can, whatever you're mentioning in terms of that. And then if you are quite happy, you must also understand one thing, and which I try to tell the people that traditional medicine, they work better as a cocktail mix. Immediately you're thinking that you want to identify a compound to go and make a drug. It does not work like that. This is based on my experience because I have developed a product for sports injury, for anti-inflammatory, and it works better when I was doing all the concentration using a cocktail mixed. Just leave it the way it is, but testing for safety and efficacy. But immediately you start isolating compound, like how chemists likes to do that, the efficacy is not the same compared to how it was with the cocktail mix. So one really need to understand what to work with, number one. Number two, it's not each and every plant that one can just get the plant and say, now I'm gonna use this plant to do this. You need to understand the property of that plant and what you're also going to look at. Like for instance, let me give an example. If one has to go and look for some sports injury or whatever, which I'm familiar with, one look at those plants that's got anti-inflammatory properties. If the plant hasn't got an anti-inflammatory property, it's going to be so hopeless or useless or wasting your time and your energy to go and think that you can develop something of something that you don't have. Meanwhile, it is something that is lacking. So one needs to really to understand the plant, and that can take forever. So I can easily announce that I was quite happy to write a grant together with some other people as collaborators strictly for COVID-19 and to see how one can actually look at the impact of these medicinal plants for COVID-19, which we are now undergoing through the research and feasibility studies based on that.
And taking you back there as well, I mean, the custodians of knowledge when it comes to indigenous knowledge systems, IKS, are obviously the traditional healers and the older generation. Those are the custodians of this knowledge. How will we ensure that they're not disenfranchised once the medicine that we are used to are now taken to the labs? And I speak passionately about this. Even yesterday on my show, I was having a similar discussion. In fact, it was a debate because I had someone representing the Basara nation who say they can actually heal a bone that has been broken or even shattered altogether via herbs. But that has not been tested in Western labs, therefore it will not be recognized. But once the knowledge is out there and it is tested and recognized, what they fear is that they will be disenfranchised and they will not be forming part of the value chain. How can we ensure that this doesn't happen?
Thank you so much. Now you're taking me back. My company, let me know. Thank you for that. My company is Global Health Biotech. I manufacture anti-inflammatory ointment for sports injury. The people that, the shares, that's called shares in my company, I've got one is a traditional healer, where we have signed all the confidentialities, part and parcel of the company. And I've got two of my PhD students that I was training because I knew that they're not gonna get a job. It's good as well to have the company to judge. So what we did now to make sure that I don't really disadvantage the IKS knowledge, the lady who is a traditional healer. We usually sign, there is a so-called beneficial agreement, which the Department of Environmental Affairs always very strict into that, more especially if you are going to commercialize the product, so that they can make clear that you are not manipulating and you are not taking the advantage of the traditional healer or the IKS knowledge holder. So with that, it was very clear from the beginning that everything is in black and white. I've also filed a patent from my work, and then I'm not the owner of that patent, by the way. It's not my name as well. The name, those people who are holding, who are the name of the patent, also the name of the traditional healer is there. Her name is there, my name is there, the other students' names, they are also there. By doing so, you become transparent and also to show that everything is clear. So we in my case, I really didn't disadvantage, and it is very clear that the lady has got a share and is the shareholder at Global Health Biotechnology, the Global Health Biotech. The lady has got, I mean, it's not only acknowledgement, whatever I'm doing. I mean, there are just so many things that I'm doing to make sure that I don't, or I didn't take advantage of the pure traditional healer, to make sure that I steal their knowledge and run away with it. By the way, the plants that I've used that I know that it can induce bone formation. Mine, I have proven it in the lab, hence I've got a patent, because when you file a patent, they also wanted to find out what is uniqueness of that. And I've got that, it has been patented in South Africa. We have just filed in Europe, and it has also been accepted again in Europe. Again, there are documents that one has to sign to make sure that you follow up, especially if you're going to commercialize the product.
Thank you so very much, Professor. You've been very clear, and I'm going to pose a challenge to you. I'm going to bring imbizayami, my concoction that I make, and I'm going to ask you to test it in your lab. We're going to get the right components that are correct, you know, according to Western medicine, and the mbiza will be on the shelves very soon, right?
Absolutely. We just have to make sure that safety, efficacy, ingredients, we do the proper. It will be there. If you Google my
Oh my goodness, there goes technology. I think we've lost Professor Mdaung, but that last comment was just me putting out a challenge to her as a sidebar, as a side note. Thank you very much, Professor Mdaung. And her company name is Global Health Biotech. So if you wanted to Google, as she was mentioning, I think you can just go and Google Global Health Biotech and see the work that she does there. Thank you very much, Professor. And it's time for us to now take a short ad break. After that, we'll have the honor of seeing a video where Dr. Pablo Vargas is going to be talking to us about remote teaching for dental students during COVID-19. And this is a perspective or experience from the Brazilian students. Remember that we do have a WhatsApp number, which is 064 656 0131, that you can send your comments and questions to.
When you look at laser dentistry, which I think is important, why we went into the oral healthcare profession, it's got to work, meaning that we do need clinical outcomes. What if I provide something that's able to at least decrease pain, but sometimes even pain-free? If you have periodontal laser procedures, you're taking an ibuprofen. You're getting up the next day. Patients are going to want laser for dentistry. They realize that they're going to have minimal discomfort. It's going to be faster than other procedures. I highly recommend, if you want to be successful for the next 5 years, you've got to start doing minimally invasive dentistry.
It's time for us now to enjoy the video by Dr. Pablo Vargas, who's joining us via video all the way from Brazil. I did mention his bio a bit earlier on. He is a dental graduate of UNESP, Uruguay in Brazil, and obtained his Master's of Science and PhD title in Oral Pathology at UNICAP in Brazil. He worked as an honorary senior lecturer of the Department of Oral Pathology of the University of Sheffield in the UK between 2005 and 2007, and is a fellow of the Royal College of Pathologists in the UK since 2013. Dr. Pablo Vargas is giving us the remote teaching experience for dental students in Brazil during the COVID-19 pandemic.
Good afternoon, everyone. It's a great pleasure to be part of IADR South Africa. First of all, I'd like to thank Dr. Belinda Boom and Dr. Nelson Fernandes for inviting me to give this talk named Remote Teaching for Dental Students During COVID-19 Pandemic, a Brazilian experience from a dental school. I think everyone knows where is located Brazil. Brazil is located in South America, and I've been living in São Paulo state for many years, and I live in Piracicaba now. And Piracicaba is a city in the countryside of São Paulo state that is 106 kilometers far from the São Paulo capital. So when you arrive in São Paulo airport, Guarulhos airport, you have to travel 2 hours by car to Piracicaba. This is a panoramic view of our dental school. It's an old building, but it's very big. And Dr. Nelson Fernandes, Belinda Boom, and Prof. Willy van Heerden visited us a few years ago and deliver nice talks for our students as well. I had the opportunity to visit South Africa in 1998 for attending an IAOP meeting in Cape Town, and I spent a month in 2014 in the University of Pretoria with Professor Willy van Heerden and Dr. Belinda Boom. It was a fantastic experience. South Africa is amazing and beautiful country. The food is fantastic, wine, and the people is very gracious. So I can't wait to visit you again, guys. This is Nelson Fernandes trying to wear the best football t-shirt in the world. That is the Brazilian team. Professor Will and I during a classroom in the University of Pretoria, and Belinda and I doing some shopping in Johannesburg, if I'm not wrong, We took these pictures in 2014. Time flies. I took this picture of Nelson Mandela at the airport of Johannesburg. I'm sure we miss this gentleman, this beautiful smile, this good soul. In my opinion, Nelson Mandela was the most important and influential political person in the 20th century. We started to work with virtual reality almost 10 years ago. I visited Amsterdam and I did a hands-on with Simon Dental Trainer. I visited the factory of ACTA and a factory of Moog, and so we could meet the engineers, the idea behind this dental trainer. And we got very excited and we wrote a few grant applications and we got 5 equipments for our lab of virtual reality in our dental schools. In our opinion, the Simon Dental Trainer provides high fidelity simulation and training and helps students to learn better, faster, and more efficiently. Okay, this picture showing our lab with 5 equipments. The equipments are very, very expensive. This is one limitation of these dental trainers. Here's an image of one student drilling a tooth. You can use it as a cardiology, prosthetic, or endodontics. So there are 3 softwares that you can train your students in virtual reality. There are some important aspects that is the Sinodont. You only need electric power, okay, because you don't need plastic teeth, you don't need other equipment that can make the costs higher. So I think it's a valuable equipment and that can be used during the pandemic. We are not using it in our dental school because it's closed for students, for undergrad students, but we intend to open our lab of virtual reality very soon for our undergraduate students once again. Digital pathology. We bought this equipment that is a perio scan scope scanner, CS, in 2011. So we changed the teaching of our students, undergrad students and the graduate students in our dental school here in Piracicaba, São Paulo State. We start to digitalize the glass slides, create images and teaching the images on the screening of the computers. So it's very good for sharing cases, to immunohistochemistry quantification when you're doing research or for diagnostic purpose, image analysis, artificial intelligence applied to histopathological diagnosis as machine learning and deep learning as well. There are a few advantages like more ergonomic, larger field of vision, easy navigation, storage, and remote access. There are a few concerns as well, as if you do digital pathology, you create an extra step in your lab. And the quality of image, I think the quality of image is quite good today, so it's not a concern. If the image is not proper, you have to scan it again. The costs, of course, because the equipment is a little bit expensive for underdeveloping countries. Threats to job security, need for fast, high-capacity servers in our institutions, and lack of experience increases time of diagnosis. You can use it is teaching, education, training, expert consultation, academic meetings, or fully digital pathology setup. The teaching, education, and training in digital pathology has been intensified after lockdown back on March 3rd until present. And promoted by the need of keeping up with activities and pathology service while ensuring social distancing. So the digital pathology is a good tool to keep social distancing. We also published a paper showing this transition between glass slides and digital pathology. This paper was published in Medicina Oral in 2015, and our students, they prefer the digital system. 98.7% of the students thinks that digital system is easier to manipulate, requires less time to identify histological structures, and provides better definition. Conventional microscopy should not be completely eliminated. I think this is the feeling, this was the feeling during the transition. If you teach the students only with digital pathology, they will not miss the traditional microscopy. As advantages, students can easily access the platform and visualize digital slides at any time, not limited to laboratory schedule, no costs with equipment and microscopes for practicing. The set provides consistency and in training among students through years, and general dentists don't need to learn how to operate a microscope. This is a histological figure of a pleomorphic adenoma, that is a benign salivary gland tumor. We also created digital material for teaching 5 years ago, where we put all information of clinical features, histopathological features, and X-ray for our students. It's an online book, okay? And if you click in this microscope figure, you open the whole slide image in your computer on the mobile phone. So it works very, very well. As you know, WHO declares COVID-19 as a global pandemic in March of 2020. A day after this declaration, our rector of the University of Campinas canceled all the presential academic activities in the campuses to reduce COVID-19 transmission, and only hospital and health workers could continue to work to fight COVID-19 and other diseases. So we had to use all our digital material that we developed for many and many years, and doing remote teaching using Google Meet platform. We thought that this could be a transitory situation, but we were wrong, and continue teaching our students online only. We started the post-graduation routine case discussion using Google Meet platform and scan slides. This is a HE stain showing a case of mucoepidermoid carcinoma. You can see here the mucin plugs in these areas. We also invited colleagues from other parts of Brazil, like Professor Fábio Pires from Rio de Janeiro, to give talks to our students. And colleagues from other parts of the world, international speakers like Professor Keith Hunter from University of Sheffield in UK, Professor Raghu from the University of Manipal, India. He gave a very interesting talk about oral submucous fibrosis that can progress for oral cancer. We also started to use more frequently the Google Class tool. So every single discipline has a Google Classroom. So you can interact with your students, posting reminders, chapter of books, papers, videos, links, and they can ask questions for you and for other students. So I think it's a fantastic tool that I was using since 2015, and I'm sure I'm going to use even more after the pandemic of COVID-19. We also started doing our thesis defense using Google Meet platform, but every single defense must be recorded and the whole process must be sent to the post-graduation secretary just to confirm that the student was approved by the internal and external examiners. We also used the set of slides from University of Pretoria and Cefaco University. So we scan all slides that they sent to us by snail mail and try to interact with our students and discuss this challenging case. If you click on this microscope, you are going to see a whole slide image. So every single student can access these cases from home. So it's a very nice tool that everyone can work from home. Here's a picture of the past. In 2019, we had the histopathological seminar in a traditional room. No one of our students were wearing masks because we didn't have this challenge that is COVID-19. We discussed the set of slides. For example, with the case of adenoid cyst carcinoma sent by Professor Willy van Heerden with our students in a Google Meet platform. Here's an image of Professor Willy van Heerden when he gave 2 talks to our students discussing his case, all the details, and we posted in our Instagram, Stomatopathologia Unicamp. Thank you, Professor Willie. Here is the set of slides sent by Professor Belinda Boom. Thank you, Belinda. Our students love the cases and learn a lot. We also started a new multidisciplinary team that we call Roman Carlos Challenging Cases, where we had the opportunity to discuss challenging cases every month with big names of our pathology around the globe. Here's a case with a big lesion in maxilla that was removed, and the diagnosis was a fibrous dysplasia. And we discussed this case together. Sometimes we get a consensus, sometimes don't, but we try to do our best for our patients. Here is the image, print screen of our group. Here's Dr. Leticia Ferreira, that works in California, USA. It's me, Roman Carlos from Guatemala, Mario Romanashi from Rio de Janeiro, Manuela Martins from Porto Alegre, Rio Grande do Sul, Brazil, Paul Spade from University of Sheffield, UK, John Wright, University of Texas, Dallas, US, and Willy van Heerden from University of Pretoria. Okay. This is a picture of our last presidential congress that took place in Alagoas, Maceió, in northeast region of Brazil, and the last Brazilian meeting of digital oral pathology that took place in Natal, Rio Grande do Norte, another state in the northeast region of Brazil. The northeast region of Brazil has beautiful, beautiful beach, coast, and nature. We also provide more online activities for our members and SOBEP. So we did lives on Instagram and created a YouTube channel for our society. So we recorded the lectures and post these videos in our YouTube channel, and all this material is free of charge. And of course, you are going to find a lot of good content in Brazilian Portuguese, but there are good content in English as well. I had the privilege to be one of the speakers in our first online SOBEP meeting that occurred in July of this year. In my opinion, it works very well and it was very successful. It was very well organized by our president, Professor Manuela Martins. This is my favorite fisher, my son, David. So, Professor Felipe Fonseca, that was my student, the Master Science student and PhD student, he wrote that the advantages of virtual microscope in teaching of histopathology may lead to the complete replacement of conventional microscopy by virtual slides in the near future. I agree with Felipe 100%. We also validate the digital microscopy in the histopathological diagnosis of oral diseases. I recommend the perusal of this nice paper that was published in Virchow's archives. We found a a high level of inter-observer agreement between two pathologists using the traditional method and the digital pathology. COVID-19 pandemic calls for urgent need to reorganize service enrolled in red neck cancer diagnosis. We made some adaptations, a few adaptations in our pathology lab workflow. Like we have to check temperature routinely. We did staff rotation, disinfection of surfaces, biopsies, plastics containers. We invested in exhaust systems. The masks should be disinfected before being discarded. And digitalization of the slides by one technician and remote analysis by the pathologist team. So we increase a few steps in our lab to keep our team safer and deliver a precise diagnosis. No one of our team got infected by COVID-19 so far, so it's a good achievement so far. This is a scheme showing the lab with social distancing and a good cleaning area with exhaust systems. So, how to mitigate the impact of pandemic COVID-19 outbreak on oral and maxillofacial pathology lab routines? So you have to do a few adaptations in the lab workflow to ensure social distancing, digital pathology to limit the spread of SARS-CoV-2 while maintaining essential diagnostic service. What is the limitation for a fully digital pathology setup? Is the lack of slide scanners in the majority of educational centers, university, labs in the field of oral and maxillofacial pathology. Why? The costs of each scanner is very expensive, is around 100,000 US dollars. So it could be a problem for underdeveloping countries. But we have our scanner here. I know that University of Pretoria bought this equipment a few years ago as well. So I'm sure we are going to move for this new way to teach digital pathology or to teach our undergraduate and graduate students in our dental schools. I think there is no return point when you introduce these technologies in your routine. This is a photo of our histopathological routine previous COVID-19. No one was wearing masks, and we look at relaxed and calm discussing the case. And this is the new normal, where we discuss the cases remotely. We scan the slides and show the slides in our screen. We share the screen with our students and sign the diagnosis out. This is our team, it's a young team with our postgraduate students, Gleison, Karen, that's a Paraguayan student, Mariana, Maria Eduarda, Carla, Bruno, Amanda, and Fabiana, she's our technician. So we are keeping social distancing. We are doing staff rotation, and I think it's going very well so far. Well, the conclusions of our talk is we are facing a digital revolution in pathology and in dentistry as well, responsible for changing the way we teach and diagnose. Studies in oral and maxillofacial fields are scarce. This absence prevents full understanding of which aspects of oral pathology requires special attention when dealing with changes in lab workflow and possible challenges when transitioning to a fully digital future. So, in our experience, we used more Google Classroom, Google Meet, scan slides, and you can use more dental trainers, these simulators, for our undergraduate students and graduate students. This is our contribution for IDR South Africa 2020. Thank you very much. Muito obrigado.
Muito obrigada, Professor or Dr. Vargas Pablo, and we really appreciate the share and exchange of knowledge. It seems that virtual reality, artificial intelligence is really going to be the way forward. This is the new normal, digitalization of the way we learn. And I'm sure that the universities here in South Africa, alongside with SMU, have also employed some of these, because we were told by Professor Hendricks yesterday when we started that since the lockdown started in South Africa, 6,000 laptops were issued out, as well as data to various students to ensure that learning continues, although remotely. But I'm quite concerned about the fact that in one of your disadvantages, you mentioned that this 4IR implementation is good, but it could also lead to some job losses. And I think that's where we should be looking critically at how we change some of the job descriptions so that jobs are not lost, but job functionalities are adapted so that they are compliant with virtual reality as we move forward. And now it's time for us to take a bit of a break. After that, I'll introduce to you Dr. van der Walt. We are back and celebrating the 50th annual virtual conference for the IADR, and we are in Pretoria, hosted by Sefako Makgato University. It's time for us now to have a talk that is going to really inspire you by Dr. van der Walt. Dr. van der Walt is a chief scientist at the South African Nuclear Energy Corporation, and he's going to be talking about plasma technology and the advancement possibilities for the medical industry. If you've got any questions, please remember to send those questions and comments to our WhatsApp number, and we will filter them through to Dr. van der Walt. The number is 064 656 0131. Thank you very much for joining us, Dr. van der Walt, and I'm going to hand over to you so that we can learn more about plasma technology and the advancement and possibilities in the medical industry.
Thank you for the kind introduction, Patricia. I appreciate it.
Thank you very much, everyone. Thanks for the invitation to this conference. I really appreciate it. So my thanks goes out to the organizing committee. I'm going to introduce plasma technology and tell you about a few different applications that there are and explain exactly what it is. Before I'm going to also say where and how plasma technology could be applied in the medical industry. I am a plasma scientist. I am not a dental scientist. So Dr. Zodwa Zwane from Sefako Makgatho University invited me here, and we are starting collaboration in this regards. So a plasma is lightning, and what we do is we take lightning and we bottle it, and then we use it in chemistry. So you can really use plasma in many different ways. You can cool it down by putting a lightning bolt in the fridge, so to say, or you can use it in the high temperature that you have it here. So there are essentially two types of plasma, cold plasma and hot plasma. On the picture on the left-hand side, you can see different varieties of plasma. Left top is the lightning bolt, which is extremely hot, as you know it. And on the left picture on the right-hand side, you see the aurora borealis, which is actually a cold plasma. The middle two pictures are human-made cold plasmas. They are inductively coupled and corona plasma. And then at the bottom, you've got what we call thermal plasmas or very hot plasmas. Now, this differs from flames. A plasma is not a flame. A lightning bolt is not a flame. For a flame, you need oxygen and heat and fuel. And with all this, you can actually make something happen, like a burning boat or a computer that exploded, or you can do something useful with it, like an incineration system, or quite a lot of other things, like heating your house. But the essence is a plasma is not a flame, and a flame is not a plasma. The big difference is really in the temperature. So a plasma can work from temperatures, I've written 1,500 to 20,000 degrees. This is for a high temperature plasma. Cold plasmas can even work at 50 or 30 degrees, where a flame is really starting to get going above 450 degrees and preferably above 600 degrees. But enough oxygen can actually elevate the temperature of a flame to much higher temperatures. So for a plasma, you do not need oxygen. You can make a plasma out in space if you would like to do, where with a flame you really need oxygen, and many buildings have got fire retarding systems by flushing a room with carbon dioxide, actually depriving the flames then from oxygen, and then it will die. So there are a few other attributes of plasmas. Small concentrated heat, which is a plasma, and flames are actually quite big if you compare them from an energy perspective. So a plasma is also called the fourth state of matter, after liquid, gas, and solid. It is a mixture of electrons, ions, and neutral particles. Excited state species and ground state species, they are responsible for the luminosity of a plasma, for the brightness. And the negative and positive species balance each other out. So it could be magnetically manipulated if you would like to do so in certain instances. And the photons emitted by electrons is called the bremsstrahlung. So plasmas are really, as I said, the fourth state of matter. And in the picture on the right-hand side, you can see that the ions, atoms, molecules, and electrons that makes up the plasma actually creates extremely high energetic gaseous volume in this plasma. And this is a huge advantage of a plasma above a flame. So, as I said, you get two different types of plasmas, thermal and non-thermal. And as you can guess, thermal is hot and non-thermal is cold. So on the left-hand side, you can see that there's a non-transfer arc plasma or a transfer arc plasma. I'm going to go into the details of just what each of them are. Radio frequency or RF, microwave or MW plasmas, and then there are some others as well which are much more specialized. On the right-hand side, you can see the non-thermal type of plasmas. They have also radio frequency but glow discharge, low temperature plasma. Microwave glow discharge plasma. Then you get dielectric barrier discharge plasmas, pulsed power, and corona plasma. So on the right-hand side bottom, you can see an example, a huge example, which is extremely well known in everyday life that we use, and that is lighting. So fluorescent lights, your photocopy machine, many other lights uses plasma technology, and even some of the older televisions, which are called plasma TVs. So plasmas are also in partial or not in local thermodynamic equilibrium. Some plasmas are collision driven. The high temperature plasmas or thermal plasmas work at higher pressures, where the lower temperature plasmas work generally at lower pressures below atmospheric. And then you get some examples of plasma is, for instance, thermal plasma, melting furnaces, like with Exaro and Implant and those companies uses melting furnaces. Welding arcs are very well known. That is also a good use of a plasma. And then some analytical instruments like inductive coupled optical emission spectroscopy instruments uses plasma. Other applications like plasma spraying and nanoparticle production. Non-thermal plasma are used in fluorescent lights, in TV, photocopy machine lights, and microchip industry, and also nanoparticle production. So industrial thermal plasma technology applications. First that I did mention was transfer arc plasmas. So this is a melting furnace where from the picture on the right hand side you can see that there's an electrode protruding through the roof, and you create a plasma flame in the middle of this furnace, basically melting all the components that you introduce into the furnace. This melt will then obviously consist of a molten metal in the bottom part of the furnace and a molten slag on top of the furnace. So the energy efficiency of this is very high. There might be some contamination due to the erosion of your electrodes, and some conventional material can be melted in this, like iron and platinum and those type of materials. The next type of plasma is the non-transfer arc plasma. So the biggest difference between the previous plasma and this one is that your molten material in the transfer arc plasma forms part of the electrode. In a non-transfer arc, like you see here, you've got a torch, and inside the torch you generate your plasma arc, and then by introducing a gas into this torch, you can make a tail flame blowing out of this torch, like you see in the middle picture on the right hand side. Now this tail flame is also extremely hot. Although that is only a tail flame with a combination of your energetic gases, but it's still 8,000 plus degrees at the exit point of this plasma torch. So you use non-usable water-cooled electrodes, the energy transfer into the tail flame, and this is then transferred into your reactor where you want to do your chemistry. And this is used in plasma spraying, in mineral beneficiation, and in waste destruction all over the world. So plasma spraying is actually a big application nowadays, because the advantage of this technique is you can take an inferior material and you can coat it with a superior coating, giving it properties that the material would, under normal circumstances, not be able to withstand. So for instance, you can coat a stainless steel tube with titanium particles, and you can give it an extreme hard coating where the stainless steel on the inside is very pliable and bendable. And this is the possibility with plasma spraying. So in the tail flame of this plasma tail flame that you saw in the previous system, in the previous picture, you actually saw the tail flame, but there we introduced the particles in the hot zone just as the tail flame comes out of the plasma torch. In this process, the particles are molten, and as you can see, those bright sparks that are shot towards the target on the right-hand side of the picture is then the molten particles being deposited on the target. So these little molten particles
are still particles which is molten if they fly, but as soon as they strike the target, you call them a splat. It is not a real scientific word, but someone mentioned it and it's easy to remember, so it's a splat. So that splat morphology is extremely important. If the molten particle splats onto the surface and it can then penetrate the roughness of the surface, the molten particles can stick to the surface. And there's quite difficult studies going on to research the properties of the surfaces where these splats stick to. So substrate roughness and oxide layer is extremely important. And then if you heat up your particles too much or you shoot them too quickly, you can get a splashing instead of a splatting. So splash you can see on this one picture, third from the bottom. You'll see on the right-hand side there's a nice round picture, and on the left-hand side there's a little round center with some splashing that took place of the molten material. And we would like to see splatting because that's controllable. So the substrate temperature is also important. The cooling rate of the substrate is very important as well. And then the splat temperature evolution is important. If any of this is too quick or too slow, then your splat coating layer can actually then be removed from the substrate by expansion properties of the material. So the coating formation can be done in various ways. You can get different splat patterns. You can imagine for yourself if you have a plasma torch and you have one pass over the substrate, then you have one layer of splats. And if you have more than one pass, then you can make a denser coating. So residual stresses obviously increases the more coatings you have and the thicker the coating is. But so splat quenching, expansion, mismatch, you must avoid temperature gradients and phase changes. These are all factors that influence the residual stresses. And the substrate and coating temperature control is extremely important here. The next type of plasma is induction plasma or radio frequency plasma. Here you don't have any electrodes. So there's no chance of contamination from these electrodes. In essence, this works at a frequency of 13.56 megahertz. And by having this frequency and generating a small little spark inside of the working coil, as you can see on the right-hand side pictures, you can generate a plasma under either low pressure regimes or also under atmospheric pressure regimes. So this is used in plasma spraying as well, some analytical instruments, waste destruction, and many applications in nanoparticle production. A new application here also is what they call spheroidization. This is where you have rough particles, small of about 100 microns in size, and you need to do 3D printing with them. If they do not flow freely, then 3D printing won't work well. And by spheroidizing them, making these rough particles spherical, then you can get them nice and free-flowing. Microwave plasma is not a very well-known plasma, and because the technology was such that microwave technology only went up to a certain amount of power, but nowadays you get 100 kilowatt or even half a megawatt type of microwave systems, and so plasma applications could also be done there. So you can see the uses there: off-gas treatment, nanoparticle production, surface etching, and chemical vapor deposition. Industrial applications for non-thermal plasma. Again, microwave applications. These are much smaller systems, so you can use them in nanoparticle production on low pressure systems. Microwave systems are mainly used in coating of nanoparticles. So, for instance, you've got an iron nanoparticle and you can coat it with a titanium layer, and this you can do with a microwave plasma. Big application is artificial diamond growth and chemical vapor deposition. If you use induction plasma or radio frequency plasma and you decrease the temperature, then you get a glow discharge. This is a low temperature plasma, and you can actually touch the tube there by the shiny part, as long as you don't touch the coil, because there's quite a bit of electricity flowing through there. Uses there is for surface modification, surface etching, also chemical vapor deposition, and lighting. A fairly new type of plasma that where the application base increased in the recent past is the dielectric barrier discharge. This is in essence two electrodes with an insulator in between them, and you generate a plasma on the one side of the dielectric barrier. So this frequency of this plasma is not as high as radio frequency. It is about 100 megahertz. It is used in ozone production and in medical wound care and other medical applications. One of the final types of plasma that I want to present to you now is corona plasma. This is where you also have a fairly high frequency between two electrodes. There is very, very little chance of any electrode erosion taking place due to the non-thermal or cold plasma that you have. And this is mainly, as the left-hand top picture shows you, off-gas treatment from restaurants, ozone production, and also surface activation for ligand addition. So some tools that we use in the plasma industry is, for instance, your plasma chemistry. I wrote there thermodynamics versus kinetics. These are the two physical processes that governs the production of chemical compounds. Kinetics is how quick a compound is formed, and thermodynamics is could it be done due to the natural laws. So if you, for instance, force a chemical reaction to be cooled quickly, so you limit the time that the reaction can take place, then different compounds can form. And this could not then be predicted by using normal thermodynamic laws and programs. So in this, we do molecular modeling and to try to predict then what happens under plasma conditions when it is not easy to predict according to thermodynamics what products will form. And then another one is your chemical CFD modeling, computational fluid dynamics. So this is where you can model your system. For instance, the reactor that you use where your plasma burns into, or your plasma torch, and you can use this then to do a lot of optimization of your equipment without even doing an experiment. After you've done this modeling, obviously you need to do experiments, because in actual fact, modeling is not supposed to tell you how your experiment should be done, but your experiment should tell you how modeling should be done. So there are a few parameters that you can look at, like the residence time of your gases, flow characteristics, temperature profiles, cooling characteristics, and so forth. The CHPC collaboration that one can have, they've got a very big computer where your modeling programs can run on, and there are many CPUs in this computer, as they say, to make the computational times much quicker. And then some high-speed cameras can be used also in your experimental parts. So you can do two-dimensional CFD modeling, which is much quicker to solve if you set it up. And this is basically to make sure that your maths and your physics is correctly applied. Because of the quick solving, you can change your parameters much quicker, and you can get your a feel for your process much quicker. From here, you go to your three-dimensional fluid dynamics. The solving time of this can be from hours to days to weeks if you do not have this very big computer. But you can get extremely good information, and you can really then, if you compare your modeling results, with experimental results, you can build up a model that can do predictions in the real world. So some plasma applications. I'm coming from the nuclear industry, so I obviously apply my plasma technology to nuclear waste treatment. One of them are low-level nuclear waste, and there's a big volume of this generated on a yearly basis. So I can really reduce the volume of this low-level waste by 90%, which is a very, very big thing in our nuclear industry. So in this plasma, because of the extreme temperatures, you don't need any sorting. So no human need to go into this low-level waste and sort out metallic parts or glass parts from the waste. I can introduce everything into the reactor and thereby treat it safely. So I can also do then uranium recovery, vitrification, which is the formation of glass. And then as I said, I treat the whole drum of the waste, so we don't need to do sorting. There's an increased chemical and radiological safety due to the fact that you do not need to sort. The technology is mature and it is applied already in some nuclear sites. So it is not as if we are inventing something brand new. And then the plasma, because of the very small torch, has got a small footprint. Now I'm getting closer to home. The surface treatment for medical application. You will remember the picture on the right-hand top side where, which represents plasma spraying. So if you spray medical implants with titanium fine particles, then you can create an increased surface area where you can get a superior tissue adhesion on those areas. In a proof of concept test, a doctor from Cape Town University supplied us with the left-hand bottom piece of implant. We coated it with fine titanium particles, and this was then implanted into an animal, and this poor guy, the animal, walked again, and it was really good for him. So it was a very successful operation. Then we have surface treatment for medical applications. You will see at the bottom there's a corona plasma system. In this, we can do a few different regimes. We can have mechanical surface treatment by only having a little argon into this plasma. If you have your substrate then in between those two electrodes with the argon, then the argon will bombard the surface, and it can then mechanically activate the surface. Then you can have chemical oxidative plasma surface treatment, and in this way you can really then add a slight amount of oxygen along with argon, and what is very nice is the color of the plasma will change, but you get then oxidative activation of your plasma, and then of the substrate surface as well. So if you want to activate it and you can keep this substrate surface inert, then one can look at adhesion of polymers onto this substrate surface, and you can get superior adhesion qualities there. You can also do ligand adhesion to give the substrate different properties. In some industries you can get fire retardant properties or hydrophobic or hydrophilic properties depending on the ligand that you can add there. So the last application that I want to mention here is waste treatment. So I mentioned in the first application of our nuclear waste treatment, but you can use it for other waste treatments as well. And at Nexa we did develop some systems for different waste treatment processes. One that I did do was for medical waste as well. I've used surrogate medical waste. And I'm going to start to explain this picture from the left-hand side. So on the top left-hand side, you can see the feed shredder. Depending on the type of waste that you have, you need to prepare your waste to be able to feed it into your facility. Just right to that, you have your hopper and the feeder, which will then transfer the waste into the very high temperature reactor. So this is then in the middle bottom where you see gasification reactor. The plasma burns into this reactor, elevating the temperature there to above 1000 degrees. So that is the mean temperature. Your plasma tail flame, on the other hand, has got still an extremely high temperature, and all of your processed gases flow through this tail flame, and thereby ensuring that you dissociate almost all gases that you can have there. And in this way, you have ionic and atomic species of the feed material you feed into the system. Any metals or glass that could be molten will accumulate in the bottom of this reactor, and you will have the opportunity to tap it off in situ while the system is running. So then the next little part there is the quench probe. This is where you cool this very high temperature gas down instantaneously. So if you remember, I talked about kinetics and thermodynamics. If I cool the material, the gas down instantaneously, I force only short chain products from forming. So I only sit with hydrogen, carbon monoxide, and nitrogen, and very, very little other toxic products. So if you do have some chlorines, then the chlorine will pass through this quench probe and needs to be taken out of the gas stream, and this happens then in the scrubber part that you can see there. So this is where you will have a basic solution, and you will actually then take out any dangerous acidic compounds from the gas stream. So after this scrubber, you have syngas, which is then a mixture of carbon monoxide and hydrogen, and this has got an energetic value. This can be used then to generate electricity, or you can make steam or hot water. You can separate it to form hydrogen, or you can use a well-known process called Fischer-Tropsch to make chemicals. So there are quite a lot of uses for these. So our technology is basically the left-hand side part up to, at the bottom you can see the Nexa interface, up to that point. We would like to promote local manufactured parts, and this is why I introduced this slide. So this is a little trailer facility that we made for demonstration purposes. Later on, I discovered that this could be used for pharmaceutical waste treatment. If you tow it behind your car, and you can drive from pharmacy to pharmacy, actually destroying the waste that they have on a daily basis. But each and every component, except for the left-hand bottom and right-hand bottom ones, are locally produced or locally sourced. So the shredder on the left-hand side and the electricity generator on the right-hand side are the two parts that are imported, and they've got local agents. But at the moment we are working towards also seeing if we can get those also locally manufactured. Medical waste has got some issues, all of us knows about that. The Act makes the producer of the waste responsible for this waste. And this responsibility includes ensuring minimization of pollution and environmental degradation and consequent adverse health effects. So this limits the choice of waste treatment and disposal technologies that you have. For instance, you cannot just have a fire to treat your medical waste, or you cannot just treat it on the landfill site. The complexity of this waste, and coupled with the increased waste volumes and the limited costly landfill sites for the disposal to treat this waste, necessitates then technology to treat this waste in a better and affordable way. So the solution that we bring to the table is what I was talking about. On the right-hand side, you can see a containerized facility. Containerized means a standard shipping container where the facility is built into, and one would introduce then your waste packages into this facility without opening it or without anything happening to it. So this extreme high temperature will then basically burn everything that there is. It will melt the metals and the glasses, and you know, according to the medical or hazardous waste regulations, you have to elevate the temperature to above 100 degrees for 5 minutes. So I suppose if you go to 8,000 degrees for an instant, it would be enough. And this is exactly what happens. So after the gas, on the third point, you can see that there's very, very little other pollutants formed due to this high temperature and the quick cooling. And then by introducing a heat recovery option, one can also then optimize the system to get a significant amount of electricity from this. So this is the containerized system that I was talking about. This system was not developed for medical waste. It was actually developed for bio-waste, for wood chips. But the small modification that needs to happen and the regulatory aspect around applying this to medical waste is actually very important. On the right-hand side, you can see an operating plasma torch from this facility. And on the bottom, you can see small metal containers that were actually treated in this facility, and those little metal droplets are the molten metal. Each of them was a metal container. So in the medical industry, you also have wounds, and by applying a dielectric barrier discharge plasma, you can increase wound healing as shown in this slide. In my laboratories, I do have dielectrical barrier discharge plasma systems, but we haven't ventured into wound care yet, and I hope to, in the future, collaborate with some medical experts to actually do this. And then very close to home, dental applications. I do not understand too much. This was a picture of a poster that I saw at my last plasma conference. This is from a university in Bologna. They do dielectric barrier discharge plasma treatment of the cavities for teeth, and by doing this, the cement adhesion and sealing is significantly increased. Okay, and that was my story. Thank you very much.
Thank you very much there, Dr. van der Walt. And I've got a couple of questions for you that have come through, and I think let's go through those. Very interesting, the use of plasma, but it also seems very dangerous. You made mention that you collect lightning, and you place it inside bottles. You know, in African, you can hear the giggles in the background. In African methodology, or in our mysticism, lightning is said to be one of those things that when someone makes you angry, you just pa, and it hits on their roof, you know. Now you are able to collect it and put it in a bottle. How do you ensure safety?
Well, that was as a matter of speaking. So what we really do is these systems are using electricity to generate an arc. And similar to lightning, this arc has got similar properties. And this is what we basically use.
Very interesting.
Yeah.
So it is not the actual lightning, but it's arcs within. So no. Professor van der Walt does not do pa, and then there's nah. So please do not call him for that service. But I know there's a province that's infamous for that in South Africa. I won't mention names, so I don't want to offend anyone. And another thing here, we looked at your technology, and you made mention that you're not so au fait with the dentistry side of it. But I'd like you to take us a bit through how your other colleagues are using plasma technology within dentistry.
We started some collaboration with activation of surfaces of implants. And the one slide that I showed for the Corona system is you can have mechanical or chemical activation of surfaces of implants. So the research would go around activating a surface of a specific metal that would have been implanted, and then looking at adhering different types of materials onto the surface, and then evaluating afterwards if the stickiness of the surface and the effectiveness of the implant afterwards is increased. And this is how the Corona plasma would be used in this one. The picture of the poster that I showed almost last was a dielectric barrier discharge machine that blew the plasma out into a little tail flame, and this you can then introduce into a cavity in a wound, and you can activate the tissue in that area. There are a few things that can happen there. You activate the tissue, you can damage some of the bad cells that there are, and you can actually then promote the healing process again by using it like that.
And talking about the healing process, there's the plasma medical application for wound care. It looked very interesting because it seemed like the healing process was quicker from the pictures that you showed us on your presentation. But would there be any adverse reactions that medical practitioners would need to be aware of should they start utilizing plasma for wound care?
From what I heard by attending the conference and listening to some of the presentations, ozone and nitrogen oxides are generated in the area of the wound, which is then breaking down any bacterial, biological material that would then infect the wounds. And by doing this, you can increase the sterility of a wound and then increase the healing process as well. So from what I could understand, they did not experience any adverse effects by using this plasma. It is a very soft, if you can say that, type of treatment, but the effects thereof on a daily basis is significant.
The cost of utilizing plasma for medical waste and also wound care and dentistry, would it be cheaper than the cost of the cost that we currently incur in our medical systems?
The physical system is fairly expensive, especially for medical waste treatment. But if you look at the advantage that one have in doing that and you evaluate that in comparison with the current waste treatment cost that hospitals has to dish out on a daily basis for this medical waste treatment, then the treatment cost is much lower, significantly lower, by using an on-site waste treatment facility. We've done some techno-economic calculations, and this really shows that a system like this could be paid off in a matter of about a year. If you compare that to the original conventional medical waste disposal, where someone come and fetch the waste on your site and take it away, and you hope that they dispose it efficiently. The other medical waste, medical treatment by plasma technology uses a different type of power supply, which is much less costly. So these are, I suppose, similar to other medical instruments, relatively expensive, but the benefit is significant in the fact that one can then use it for many, many patients, and your time in hospital could reduce due to increased wound healing.
Well, secretly there, I must say that, Dr. van der Walt, I was really hoping that you were going to say you do sell lightning in a bottle, because right now I feel like showing some people some flames. But with that being said, I think it is beautiful that most of the machinery that are used within your technology are South African created.
Yes.
So that means job opportunities are opening up, and we are heading towards a new era when it comes to the technology that is used. Thank you so very much for joining us, and we really do appreciate you.
I appreciate it. Thanks.
Let's go to a quick ad break, and after that we'll be back because we have Acting Director General for the Department of Communication and Digital Technology. After the ad break,
Meet Janet. Janet is the manager at a really busy dental practice. Her boss, Dr. Jones, wants her to improve the productivity and profitability of the practice. She's already working to the max. What Janet really needs is an easy-to-use online ordering system that really simplifies her day-to-day ordering process. Luckily for Janet, there's a better way. Introducing My Right Place. At Wright Milners, we've always worked hard to offer you the very best value for your money. And now we're really excited to be able to offer you the very latest smart solution. Okay, here's how it works. A Wright Milners representative will come to your practice and help you set up and personalize My Right Place. We'll help you set up individual users and you can tell us their budget. Make your very own bespoke catalogue using your preferred products and brands. That's it, you're ready to go. Simply log on to our website and start saving. With just a few clicks of the mouse, you'll be able to compare your practice's overall spend, not only month by month and week by week, but you'll also be able to drill down and compare individual practitioners' spending habits. My Right Place is intuitive, simple to customize, and will allow you to see real-time savings for both you and your practice. So let's summarize. My Right Place. It's simple to set up and manage. It's easy to set up individual spending limits. And you can create your own bespoke catalogues. My Right Place from Wright Milners.
We are back and still celebrating the 5th annual virtual conference for the IADR. My name is Patricia Ntuli, and we are in the last segment for the second day. Still very interesting. And before that break, we had a very, very interesting, eye-opening presentation by Dr. van der Waals talking to us about plasma technology. So before we allow Dr. van der Waals to go, we'd like to give him a token of appreciation. If Professor Hendricks could please come forward to give the token of appreciation.
Thank you very much for your exciting and intriguing
Thank
and
you.
enlightening. And we hope to learn more from you and acknowledge that you are using, especially the waste, destruction and processes. And surely for our country, that holds in good promise. Thanks
Thank
very
you.
much.
I really appreciate it. Thank you very much.
We are looking
Wow.
forward to the lightning in the package.
Thank you very much. I appreciate it. Thanks.
Well, it is with great pleasure that I am introducing the acting the acting Director General of the Department of Communication and Digital Technology, Ms. Nomvuyiso Baki. She is in charge responsibly on the developing strategy and implementing them for South Africa in the department, as well as ensuring broadcasting and postal services, and also to ensure that there is a 5G policy framework that will support services like the health and education and the likes. Warm welcome to you, Ms. Nomvuyiso Baki.
Thank you for having me, Ms. Ntuli. I enjoy being here.
Now, you know, you chastised me before we came back on while we were having the ad break. You were like, Patricia, 4IR and those papers in your hand. And you were telling me a little secret about what happened when Minister Stella Ndabeni came into the department.
Yes, when Minister Stella Ndabeni-Abrahams came in 2018, she actually directed that the CFO buys laptops for everyone. including the lowest paid employee within the department. And she actually said no more printing of any, she said you must actually do the cost of how much it is to print at the office, no printing of business cards, no, we must minimize our printing costs, and the laptops were actually bought for everyone. By the time COVID came, we just converted ourselves into a project-based organization. It's been tough, only a few of us are taking on, but we've been ready. We carry our devices everywhere, so we did the uptake. So we're ready, thanks to her vision as early as 2018.
Well, we're hoping that that vision is going to infiltrate into the rest of South Africa. And we heard that there's a lot of technology also around. You heard about the plasma technology, and I think that probably intrigued you as a department that's looking forward to new ways of technology and how we can implement them, especially in the health sector, which is one of the sectors that were hardest hit by COVID-19.
Actually, one of the things that we noticed during COVID-19, what we supported were actually two sectors, the healthcare sector and the education sector. And we noticed that in the healthcare sector, because we are mainly responsible for communications and ensuring that there are systems that are working. And we said, what is the main thing that can drive communications for the healthcare workers? And we said, free services for people, such as ensuring that there is an app that will tell you how far are you from the person that is infected or possibly has been in contact with somebody with COVID-19. So we made sure that that app is zero-rated. And we also ensured that health services sites, that the websites that you go, let's say the SA coronavirus website, is actually zero-rated, as well as the WhatsApp line was also zero-rated. So even if you do not have airtime, even if you do not have data, even now you notice that today there's a challenge with network connectivity from the purposes of broadband, that you will still access those services. But we notice that once we have all of those things, unfortunately, that is available. You would notice that the greatest people that have been at risk of COVID-19 are rural communities. So where is the risk? It's in education.
Definitely do agree with you, and I'm sure that the talk you're going to deliver to us is going to inspire us, and especially because this is a centenary celebration for the IADR, and worldwide, COVID-19 has hit us hard, but we have had to learn how to leap forward. We have had to learn how to use technology. And even in the rural communities, we are hoping there will be access. Please take it over and let us know more.
All right, thank you. I know earlier that you had Professor Marwala. I just need to just go back just a little bit. That we had as a department that we knew that FYR was coming, and we put a proposal through our minister that said there should be a presidential commission set up, which was a 30-plus commission, which commission was then designed to assist the president and advise the president to say, what does the future in South Africa for FYR mean, and develop a blueprint for South Africa. The FYR commission was around for a period of about 15 months, and they developed the blueprint for us. And I'm sure he took you into detail, and they had 8 recommendations, and we're happy about those 8 recommendations. So my role in the department, I'm also the head of the project management office for the 4th Industrial Revolution. Ours is to make sure that we have a strategic integrated plan for South Africa at intergovernmental level as to how we ready South Africa for the 4th Industrial Revolution. There is no point for South Africa to have 5G technology, to have all these technologies, if, to your point, Professor, if we do not have our own capability that is built for South Africa, in South Africa for South Africans. So that is the whole point of making sure that we have an integrated strategy as South Africa. So we've seen that with COVID-19, the experience that we said, our future, then when the borders closed, We were one of the most fortunate departments that we had the laptops. But there were people that waited for the laptops, that the borders were closed, you couldn't get technology, right? People, there was a shortage of oxygen, oxygen tanks. We know this, it's still a challenge here in South Africa. What is it that we can do? So now we're saying as a department that the magnitudes that is still being caused by COVID-19, the thing that we want to focus on in our implementation plan, the first one is education, right? So we have education as part of our recovery post-COVID-19. Why would you say, why do we say education? Think about it here. As we're sitting here at this fancy hotel, most of us, and I say most of us have children, right? Our children had the benefit of studying virtually, right? However, when you think about it, most other people in South Africa, their children didn't have the luxury of studying virtually. But if you think of the cost of your child studying virtually is next to nothing. And it's virtually next to nothing, but the children of South Africa, most of them do not have access to basic broadband. So when you're talking about 4IR, we are saying the future of 4IR has to start at a basic level of ensuring for health services, for education services, we need to make sure that our people are educated. So we have a digital transformation strategy that has come forth, that has been published, and we actually saying as part of that, there's a sub-structure that we have, the sub-document that we've come up with, which is called the National Digital and Future Skills Strategy, which has 8 key pillars. The first one, which is the digital foundations and basic intermediate digital skills. Think about it this way. Today, somebody, in order for them to be paid a social grant, the SRD, that is as they call it, the 350, you've read about it. We're sitting here. People are buying their space in queues for 50 rand to be paid 350 rands. What is stopping them from a technology point of view that in order for you to be paid 350 rands, why can't it be paid into a device as you are doing your internet banking yourself? So it starts at an elementary level for us that there has to be basic foundation skills for our people that you need to teach them as to not only when you're saying a learner, we can teach you a grade 1 learner coding. Yes, that is great stuff that is happening when it comes to Department of Education, basic education, we're happy, but also we need it to be coupled with another digital literacy that needs to happen to the most vulnerable groups. That is the digital foundation of the basic and intermediate digital skills. Then we have digital futures and mastery and building advanced digital skills. This is about the curriculum of the future. Fortunately, there's no one younger here in this group. I'll think about it. Most of us here, we never knew what Ritalin is. I know you're in the medical field. You never knew what Strattera is. But our children are so gifted that somebody doesn't know how to handle them. The schooling system is not designed for them. So we have to ourselves challenge ourselves to develop a curriculum that is ready for their brain. You never held a device. Remember, you were young. You were told, do not touch the phone. Remember that phone? Do not touch it. But your child, as young as 6 months old, you give them a device. So now, how do you make sure that a curriculum is ready for that child? That child that when they go to school, because a poor teacher that is our age cannot handle that child and says, this child has ADHD, this child must be on medication. And we're not saying they are not, they do not need the medication, but we're just saying also the curriculum is not preparing them because the child, they cannot cope with the current curriculum as it is. They require a curriculum that is ready for them. So we did a number of studies. You go to countries such as Belgium, curriculum that is tailor-made for children of today. What is difficult for us? Our generation is young, but our children are still, I'm sorry, what is the book that we used to do? Jack of the Bushveld, right? My son, Jack of the Bushveld, my son is doing that book, and I have no offense to the person that wrote that book, but it's still being applicable. So it's that kind of situation that I was looking at. Skills for Industry 4.0 and the world of work. My background, I was talking to Pumela earlier on. My background is in broadcasting. In broadcasting, you just need standard 8, right? And you will have a person that just has standard 8 that is brilliant. And those skills that they have future skills. They will be able, just think about it, in audio visual, in order for you to create this video, in order for you to create this voice that you hear today, you do not need a degree. You do not need masters. You do not need doctorate. So what are the future skills that are required, and how do we ready ourselves and our children for those skills? Otherwise, we will always remain a dark continent and always be learning from others. So that is the next pillar. And in that pillar, what we've done and what Minister has introduced, we have one of our institutes called NEMISA. NEMISA is is actually offering courses. These courses, a year, like artificial intelligence, robotics, 50 students will be taken per semester. 50 students will be taken. And to our surprise, most of these students, learners, will have like grade 11, they failed matric, most of them, from rural communities. The skills that they teach them is how to fix a cell phone. I don't think it's a simple thing, but in those communities, it's how to make money, right? And they will teach you how to be an entrepreneur, how to run your business. There's one that was even published in the Sowetan. He's even running a fully fledged business just outside East London. He's only 22. And this course is not even 5,000 rands for the 6 months, but he had this in his mind, and he couldn't just execute it. But the curriculum goes back to the issue of the curriculum. It wasn't designed for him, but when he went to the application of what technology offers him. He knew this is what I need to do. In Limpopo, we had a graduation, to what now we know as level 3. With a graduation, there are 3 young people. One happens to be a lady that graduated from this course, robotics and artificial intelligence. They were showing us, saying, no, we've opened our own business. They're not asking for a job. They've already done, they've gone an extra step. They've done one in Cape Town, didn't even come to the graduation, couldn't even drive. I was like, no, I'll join online. I have a client that I need to meet with somewhere in South America. I have to meet online with my client. And these are young people. So those are the kind of skills that how do you build that? And we're saying we know that it's scary because when you think about future skills, we're thinking 4IR is going to take our jobs. So we're saying we also want to create awareness that it's not only about taking jobs. We need to build awareness that there are alternative jobs out there. There are, you look at how people are concerned, you hear that there will be job losses at the airlines. But there are alternatives in airlines. What is the alternative that is there in airlines? There's drone pilots that are coming today. That is an alternative. There was never a drone pilot 5 years ago, to my mind, but that is a profession that is today certifiable, that is coming out, and you get to have flying hours. You see, so it's those kind of things that it shouldn't be a scare tactic. But the major downfall of it's the second last thing that I wanted to talk to you about on the 8 pillars is the coordination across government and other stakeholders. As you can see, Pat, right? In government and other stakeholders, we're doing the same thing, almost like in a competitive state. You are doing your own thing, I'm doing my own thing, but we're targeting the same audience. Instead of leveraging on what we are doing and actually partnering. As a result, you would have noticed that COCTA has come up with a great model because there's so much duplication and wastage called the digital development model, not digital, the district development model, wherein if you're going to a district, say you're going to a district in Mpumalanga, when you want to deliver a service, you are Department of Health, or anyone in any other department, you cannot go there alone. You need to partner with all the other departments. You need to check, is there water there? Is there basic broadband? Is there anything else that is required? Talk to all the other departments so that that community is not found short in other services. You deliver in that space. So that is what that says, that in this 4IR world that we are going into, let's not only concentrate on the smart city that you will see outside Lanseria. Think also as to how do we build communities in a coordinated manner across the spectrum. Then, but the major issue then becomes, how do we find the skills of the future, right? Because the issue then becomes, I looked during COVID, and I'm sorry, I know this is the health, it's health and most specifically oral, but fortunately because you have cameras, I'll always go back to the sector that I know best. You saw advertising, there was no advertising on TV. Think about it, how many people have lost jobs, right? But in that job loss, there was an alternative industry that was created in that period. An industry that has been created purely because of technology. In our space, if you think about it, there was no, since you watch, I know people watch TV, the number of cooking shows you watched during COVID, right? I know, like, most of us, even people who don't know how to cook, watch the cooking show, even new ones. That was an alternative. That's what they saw. They said, okay, there's a new, everyone is cooking, even people that don't know how to cook. And that's where our creatives received an extra form of income. So there's always an opportunity for funding, but we always look from a point of lack. So we are saying that even in this future that we're looking at, ours is to say we set the foundation, but how do we partner to make sure that health, education, agriculture, whichever sector you are in, we are able to show that as South Africa, as Africans, we are able to be in this fourth industrial revolution. So you will say, for instance, you will hear everyone will make the example about Rwanda and say Rwanda is great and they're doing a great job. But think about it, how many towers do they have? And how many towers are in South Africa? And for us to do the job that they are doing, it means we have to get our acts together and work together. So, and the platforms and the materials that are going to be used in schools, somebody has to pay for them. And unfortunately, at this point in South Africa, there's very few that are made in South Africa. So what we've done, we've partnered in some instances, for instance, with institutions that are based in overseas, like Coursera. Those institutions are giving us free courses here in South Africa so that our kids are able to receive this education that is at a basic level they will be able to do. So we're saying this is critical, that even in your sector, in the healthcare sector, in order for somebody to have the best medical device that will be available, that device has to be informed by somebody that would have know-how as to how it will be used, not only import. That's why we're focusing on education. So Ours then we say the next level is to create further policies. The Professor Marola, the one that was here, says, his team says to us, you need to focus on infrastructure. Department of Communications in South Africa, we are having a serious challenge of infrastructure, 5G technology. If you hear today there's 5G technology in South Africa, which cities do you think of? Tell me, Pat.
The major cities.
Sandton, isn't it? You know that where your school is, there's no 5G, isn't it? Maybe there's LTE, right? Garangua, Mabopane, there'll be a bit of 3G, you know. We know this. So there's a focus on focus on infrastructure as to how we can have the talk about 4IR, but focus on building an infrastructure that will make sure whatever technology that comes to South Africa works. Even your technology, the plasma technology, I heard you talking about, I don't know, whichever megahertz that you were talking about, I forgot what it was. That technology, you will find that it works in certain, within a specific radius, right? And in order for it to work, there's certain dependencies that is required. So the infrastructure is at the pillar of everything else. In order for you to have a bus service that is running, a person taking a bus from Garangua to CBD, that bus service, before Minister of Transport thinks of a train, it has to have Wi-Fi connectivity, because there is no point. There is no point. That is the basis of where everything is coming at. So we recognize that everyone else is moving at a rapid pace than us. There is a challenge that, or it's not even a challenge, there is a tension that is happening globally around 5G. And we're saying in South Africa, we want to play our own game, right? And you would know that people are writing a lot of articles saying, South Africa, which side are you taking? And we're saying, no, we want to create our own space at this point, and we want to do things that will work for our own people in South Africa. So you will see then that we are focusing on a priority that says, whatever sector you are in, ours at an intergovernmental level, we want to partner with you. We want to ensure that we have the skills and we build the skills for the future. We build the skills for the future, and 4IR does not only exist in paper, because we know that there have been plans before, plans that have come and are good on paper, and those plans have not been, they have not had a basis in terms of how do you then implement them? How do you then ensure that our people are educated on those plans? And once they're educated on those plans, they're able to own and execute them. So that is where we want to make the differentiator with this one. Hence, we're saying in the literal sense, we are doing the, I don't know how to like when you want to hold each other's hands to say, guys, 4IR does not belong to Department of Communications and Digital Technologies. It belongs to all of us, but we can only show you the framework as to how it needs to be implemented. And then this is how we think it should be implemented. Do you think you're game? This is how we think are the priorities of the country. Do you think you're game? Even now, the issue that our minister is so obsessed with is the issue of education. If you were, I cannot reiterate it enough, the issue of virtual schools. During lockdown, how only 8 NHI districts could be connected. It's fortunate that healthcare services got more connection than schools. But it's because the schools were locked, whatever the situation was. Because you cannot, I mean, it's good that the health was received, but at the end of the day, yes, we'll be healthy, but who is going to derive the benefit in the long term? Because we require the children to ensure that we live longer. So with that, I wanted to make sure that the minister says she wishes everyone here the best, and we want to work with whomever that is willing to work with us insofar as ensuring that the future of 4IR in South Africa is implemented in the best way that can serve South Africans. Ngiyabonga.
Now, it's very interesting to know that there are collaborations between the government departments. But one of the collaborations that I think needs to be cemented, and you have put it correctly when you say the education department is very key to what you are doing as the Department of Communications and Digital Technology. And how do you then make sure that the curriculum is ready? Because I share the same sentiment with you. When I look at the work that my kids who are in primary school do, and even if it's children who go to private schools or government schools, it is the same curriculum. The differences are only in the high school level, depending on what exams you write. But still, it's the same. Not only the methodology of teaching, so virtual classrooms, and that is a simpler element, but it's the actual curriculum. How do we alter that? How do we alter policy and ensure that instead of teaching our children education that is not suitable for the fourth industrial revolution, we teach them what is suitable? What would we need to do, or what are you doing in partnership with the education department?
The fortunate thing that we did, that's why I'm saying the part of having the experts that we had in the Presidential Commission that actually wrote the recommendation and said, this is what you need to do. Make sure that you change the curriculum and change it in this manner. This is the strategies that you need to implement. And now, as the department, we need to ensure that the infrastructure is there. Department of Education, make sure you change your experts, because it has to come to that. Think about it this way. Professor Marwala and Night Network in Ghana, that is South African. She's never received an opportunity in our own country. So you meet all these people from diverse background. So you need to have that change of mindset, that even if you have experts that have been working on the same curriculum over and over and over throughout the years, that now you have a blueprint that has been developed by people that know another world different from you. Apply it and say, actually, I cannot use Nomvuso anymore. She's not the correct expert. I need an expert in artificial intelligence. So for example, the PMO that I'm talking about, that I am heading, I had to hire, for a period of 36 months, I'll be working with 8 experts: artificial intelligence, data law, research experts in telecoms. These are people with PhDs, and remember, I don't even have a PhD. But I recognized that the capability does not reside where I work. But in order for us to realize what is required for the future, these are the expertise that are required in the department. And each and every one of us have to realize that if you do not have the expertise, you need to take it elsewhere. And I know then maybe your next question will say, but government does not have money. There are instances that when you partner, you do not have to pay. I'm sure Professor Marwala will tell you, we didn't pay him a cent for 12 months, whatever period it was. We were just nice to him. That commission, we didn't pay them. We didn't pay them a cent because we didn't have money. We just made sure we were nice, gave them secretarial services, and took their notes, and were gracious. They were very kind to us. You see? And it's how you build relations when you know that you are at a point that I do not know, but I want to know this thing moving forward. So it's a journey that we have given ourselves. At least the next now is about, we've given, now I think we're left about, 30 months for us to finish, because we did the first 6 months so long. Yes.
Another question here is, why are we not having a centralized patient information management system in our health system in this day and age? And obviously you're not Department of Health, but you're Department of Communications.
I think that talks to about commitment to systems. Because any other, if you think about it, if in any organization you have to be committed to systems, I do not think that a Department of Health doesn't have, any Department of Health, be it provincial or national, doesn't have a Chief Information Officer, which is a CIO. And the moment you have that kind of a person, those people, think about it, all spheres of government from local, provincial to national, there has to be somebody that has to think of a system. And when you say it like that, and I'm actually thinking about it, that when I used to go to the clinic, I had to bring my book, right, when I was younger, because there was no centralized system. So, but I must say this, on that score, there is a bit of a synergy in the local government one, because my dad was with us for during the lockdown, and for some reason they were able to get his data from a local government, from a Tshwane district hospital kind of thing, but from a what is the bigger one?
Provincial.
The provincial, the Steve Biko, the Steve Biko hospital. I took somebody there; they didn't have his data, so it differs. So to your point, I actually saw there's a disjuncture somewhere. So it's about a will as to the persons that are responsible for systems. If you are in IT, you have to be thinking how the systems need to be able to speak to each other. And in this day of data protection, and make sure that, because your information is gold, right? That when I come to you as a patient, I need to know that if I change doctors, that I go to Pumela as my next doctor, that should be able to retrieve that information without a hassle, especially in the public care system. And at this point, I know, unfortunately, it is not there. And I believe we have enough expertise to be able to do that. And I just don't have a response for you, because I'm just thinking, it surely must be, it is possible.
If it is possible, then it means one of these good days it will be done.
Yeah.
Thank you very much for joining us. It's been such a great pleasure. Before we let you go, I'd like to call forward Professor Hendricks to come give you your token of appreciation.
Thank you very much for the presentation. I think you've taken us onto another journey.
All right.
And the way that you conceptualized that at our age, we're outdated. And that child at 6 years old and 7 years old thinks differently.
Yes.
And I like the example of the child of 5 months playing with a cell phone. And so I hope our teachers will be given that new expertise that you spoke about. But thank you very much. Much appreciated.
You're welcome. Thank you.
Thank you very much. Yeah, thank you very much.
Thank you.
Let's go to a quick ad break. At long last. And welcome back as we come into our last segment for the 5th annual International Association Dental Research Congress, IADR, in South African division. And it's such a great pleasure getting the wealth of knowledge from all our guests and also having interaction from you as you have logged in and joined us virtually. We know that COVID-19 has changed the way that we do things, but this new normal, definitely convenient for most of us. I mean, logging into a conference and still getting the rich wealth of wisdom and knowledge, but not having to travel far from your own home. Quite a pleasure. I'm actually enjoying this new normal. Remember, we've got a WhatsApp line that you can dial to ask your questions and also to give us your comments on 064 656 0131. Yeah, that's if you're in South Africa. If you're not in South Africa, instead of the O, it's +27. I've been forgetting to say that because I'm thinking our entire audience is aware that we're in South Africa, so the dialing code will be +27. And you can also go on to the website www.smu.ac.za/IADR/2020. Our next guest, I've been preempting for this because I think it's one of the most important and critical element of any industry, and that is the law side, the legal side. And now we're going to talk medical law and bioethics. In the helm of 4IR, COVID-19, I think medical law and bioethics is something that we need to really concentrate on. Our next guest is Dr. Minigio. She helped me pronounce it properly because initially I said something else, but it's Italian. And as you can see, I am not Italian, okay? But Dr. Minigio is a senior lecturer at the Sifakwa Mahato Health Science University at the School of Oral Health Sciences and Department of Oral and Maxillofacial Pathology. And she's going to be sharing with us right now a presentation around medical law and bioethics.
Thank you so
Good
much.
afternoon.
Good afternoon, and good afternoon, colleagues. I am honored, thrilled, and very proud to take part in this first of its kind and innovative IADR virtual conference hosted by my university. I would like to take this opportunity to congratulate SMU University of Health Sciences, our Dean and CEO, Professor Hendricks, the South African division of the IADR, and of course my colleagues in the local organizing committee for this successful and futuristic conference. I would also like to thank you for the invitation and for the opportunity to present to you this afternoon the ethics talk. My ethics journey began a few years ago, and it is a very interesting one. It began as part of my exposure to the basic oral health sciences and to laboratory medicine. And also it began with the realization that when it comes to ethics for laboratory medicine in the ethics literature, it is underrepresented. Also, it began with the realization that when we talk about ethics, particularly in the oral health sciences, both in the ethics literature and also in the way that we teach ethics, we focus most of our attention on a set of rules, guidelines, and principles. And while these rules, guidelines, and principles are important in that they tell us what to do in specific ethical context, the sole reliance on these rules and principles is a shortcoming, since the ethical decision-making process is a human endeavor. And as such, it is ultimately the individual or the moral agent who is required to firstly interpret the principles. If we think of the principles of autonomy, beneficence, non-maleficence, and justice, place them in order of importance, and then choose which ones to apply and which ones to ignore in a specific situation. And unfortunately, principle-based ethics on their own do not cater for such, for the inclusion of this important aspect of healthcare, of oral healthcare, in terms of reflections on ethics. And in my ethics journey thus far, I have explored an alternative way of thinking of ethical issues and reflecting on ethical issues, which focuses on the role of character, emotions, internal motivations, as well as relationships as part of the ethical decision-making process. This type of approach is called virtue ethics, and it is what I would like to present to you this afternoon. And I thought, what better way to discuss this type of ethical approach than to look at some of the reflections on lessons learned during the COVID-19 pandemic. So for this afternoon's presentation, we will discuss how ethical issues specific to the COVID-19 pandemic calls for a virtue ethics approach, how virtue ethics can guide us to a more moral response in the current pandemic, also how virtue ethics is very good at complementing existing principle-based ethics, and also look at how the introduction of character and emotions and virtues as well as internal motivations can assist us in better understanding the value of healthcare in the healthcare practitioner-patient relationship. So as we have seen, in late December 2019, the Chinese government sent out a public alert that a pneumonia of unknown causes had spread throughout the city of Wuhan, and soon after, this infection rapidly spread throughout China and reached multiple continents in a short number of weeks. And on the 11th of March 2020, the World Health Organization declared this as a global pandemic. And soon we witnessed our world, as we know it, change very drastically. We observed the COVID-19 outbreak and the substantial health burden globally, which created an international public health emergency. We witnessed, amongst others, various countries across the world impose various types of restrictions, both travel restrictions and restrictions on personal freedom of movement. We witnessed airplanes grounded, universities and schools close, and this big movement to online and digital platforms. And this really denotes the value that we as a society place on health and what we are willing to do to protect health as a society. And the coronavirus disease outbreak raises unique ethical dilemmas because it makes demands on society from all sectors of life and from all over the globe. So while the lasting implications of the current pandemic are yet to become apparent, we can at this point reflect on some ethical lessons learned so far. Of course, due to time constraints, we will limit today's presentation to understanding the value of character, emotions, and internal motivations in the healthcare practitioner-patient relationship. We will apply aspects of virtues on restrictions on individual freedom. We will briefly look at how virtues can assist us in assessing the economic impact and access to healthcare, as well as briefly have an overlook over research ethics. So from a virtue ethics perspective, healthcare practice is a moral enterprise. Virtue ethicists justify this by the fact of illness, the act of the profession, and the clinical encounter specific to the healthcare practitioner-patient relationship. The fact of illness originates from our vulnerability to harm from nature, environment, oneself, and other people. And because of this and our human limitations, we all stand in a relation of dependence on each other for both health maintenance, restoration, as well as health improvement. So healthcare practice is also a normative enterprise since it conforms to rules and principles that go beyond science and technology. And healthcare practice is also considered to be value-laden, since it embodies something that we value or something that we consider as an important good. And as we have seen, we are willing to shut down entire economies to protect this very important, valuable thing to us, which is health. And this is similar true in the unique patient-healthcare practitioner relationship from which a set of values arise or agreed upon within that specific practice. So if we are going to talk about a practice, we need to define what a practice is. It is a coherent and complex form of socially established cooperative human activity through which goods internal to that form of activity are realized in the course of trying to achieve those standards of excellence which are appropriate to and partially definitive of that form of activity. And what is interesting about healthcare practice and virtue ethics is that virtue ethicists consider that practices should not be identified with mere technical skills, and healthcare practice only comes into existence when it appropriates knowledge and skills in order to further its healing purposes. So within a practice, both internal goods as well as external goods can be achieved. An example of an external good within a practice is, for example, financial benefit, which can be achieved in a lot of practices and is not inherent to healthcare practice. What is inherent to healthcare practice is the internal goods. Internal goods such as excellence in healing, the unique relationship between the healthcare practitioner